Hello and welcome to the Health and Government Operations Committee. A few notes before we get started. Witnesses in this committee, the bill sponsor has 5 minutes to explain the bill, and then we have 2 minutes each for 5 proponents. And if there are 5 people in opposition signed up to testify, the bill sponsor can share extra time if they have it left over with any of their witnesses. We do ask that our members ask one question per panel, and that be directed towards one witness. So one question and one answer, and try to make sure the question is shorter than the expected answer. We generally try to break around 3:30, but since we are going back to the floor today, we're going to try and make as much progress as we can on the 10 bills that we have today. If we find that we need a break, I will make an announcement. And our first bill today is House Bill 396, Public Health, Overdose, and Infectious Disease Prevention Services Program. Delegate Peña-Melnick.
Good afternoon, Chairman Kelly and members of the committee. Today, House Bill 396 will be presented to you by my amazing intern, Allison Hortzman, and she will present the bill to you. Thank you for giving her the courtesy and time. Ms. Hortzman.
Chairman, Vice Chair, members of the committee, thank you for having me here today to present to you House Bill 396. My name is Allison Hortzman. I'm a master's student at Johns Hopkins Bloomberg School of Public Health, studying health policy and currently interning with Delegate Peña-Melnick's office. I've been very passionate about this bill since I first learned about it. As a public health student, these innovative and evidence-based solutions to create healthier communities always tend to excite me, and this bill is no different. I want to make it clear from the beginning that this bill is not a mandate. This bill does not enable drug use. What this bill does is enable localities to take action for what is best for their own communities by applying for the opportunity to establish an overdose and infectious disease prevention services program. House Bill 396 would prevent overdose deaths and transmission of disease while providing resources and access to services by allowing for the implementation of 6 programs throughout the state. These programs would provide a safe place for someone to use their own previously obtained drugs. Drugs will not be given out at these sites, and I want to make that very clear. The drugs will not be given out at these sites. But by having trained employees at the ready to deliver life-saving interventions, such as naloxone, we can prevent death from opioid overdose. These trained staff members can also provide sterile equipment to people who use drugs at no cost, can distribute clean materials, and provide referrals to treatment and information on how to get help. The evidence supports that programs such as these would lead to reductions in diseases commonly transmitted during needle sharing, such as hepatitis C and HIV. Notably, there has not been a single overdose death at any of the 150 successful overdose prevention sites in the world, spanning 12 different countries. Furthermore, the area surrounding the Vancouver overdose prevention site saw a decrease in their crime rate. The support system created by these programs is invaluable. People who use drugs are battling their own demons and the stigma that our society projects onto them every single day. The goal of these sites is not to preserve and sustain high rates of drug abuse. In fact, it's quite the opposite. These sites provide safe places to use drugs, yes, but they also provide resources and support to those who are wanting to seek treatment. People deserve this support from us. They do not deserve to risk dying alone in a dark place for something that is completely and absolutely preventable. Finally, I want to address a question that I'm sure is on your minds. Is this really the right time for this bill? Because I know that we're in the midst of a pandemic and we desperately need to focus our resources on vaccine distribution, COVID-19 tests, contact tracing, and the like. Yet overdose deaths have been increasing during this pandemic. We all know how hard this time has been on us and on our families. The layers of trauma from an opioid epidemic inside of a pandemic have been cloaked over our most vulnerable communities, and it has been suffocating. A Baltimore Sun piece from January 13th announced that 2,025 people suffered unintentional intoxication deaths between January and September. This is a 12.1% increase from the same period in 2019, just in our state. So the answer to the question is yes, now is the time. Overdose prevention sites in Maryland would be safe, and they will save lives. Every single overdose death was preventable, and every life lost could still be here with us today. We can and we must do better by those in our community who are facing the risk of overdose. Thank you for the opportunity to present House Bill 396. I respectfully request a favorable report.
Wonderful, thank you. Great job, Ms. Hortzman. We now have a panel in support of this legislation. We will see first from Brandon Scott.
Thank you. Thank you.
Welcome.
Good afternoon, Chair. Good afternoon, Vice Chair and members of the committee. I am Mayor Brandon Scott, joining you from the great city of Baltimore in strong support of HB 396. I want to first thank Delegate Pena Melnick for sponsoring this bill and continuing to be a champion for a new way forward for Maryland. I want to thank the advocates and service providers from the Bridges Coalition who do important on-the-ground work and who have been integral in building literacy and relationships around this issue. I also want to thank the families who have been impacted by overdose, those who are following this legislation. What strikes me about most cities across the globe where overdose prevention services are present is the lack of overdose deaths. Every year here in Baltimore, we lose hundreds, if not thousands, of people to fatal overdose. In the first half of 2020 alone, we lost 427 people to opioid overdose deaths. Think about the gravity of that, the amount of pain and trauma each of one of those people leave behind. We must accept that the way that we have dealt with people who use drugs and the ways we've attempted to address this issue are not only wrong, but they have not worked to save lives. I grew up in Park Heights. Many of you may know it as the neighborhood for Preakness, but where we were culturally taught to look down on people who use drugs to the point where we were really taught to not see them as human. It wasn't until I was older that I understood the realities of substance abuse use and that this was fundamentally an issue of public health and well-being. And I had to unlearn what I had been taught and know that what we had been taught was so wrong. We should never look down on our fellow residents and citizens. I know many people can share that experience. On a cultural level and a political level, we have to transform our understanding and be open to a new ways of meeting people where they are. Dehumanizing people and investing in punitive measures in response to this great challenge does not help our community stay healthy, nor does it keep people alive. This is a conversation that we've already started here in Baltimore. Last in January, I introduced 2 resolutions when I was council president to learn more about overdose prevention services and harm reduction. From that conversation, it became clear that we have a lot of work to do inside and outside city government to better support people. We're going to continue doing this work side by side with our community-based partners and advocates so we can invest in a proven solution and take action to save lives. It is imperative that we, as public servants, consider harm reduction approaches and understand why we can no longer criminalize people or look down upon people. On behalf of Baltimore, we welcome this discussion around how we can expand our use of harm reduction interventions and the number of safe and legal evidence-based tools at our disposal to save lives. And for that reason, and those reasons, I urge a favorable report respectfully on HB 396. Thank you.
Thank you very much for your testimony and for being here today. We have 4 more panelists. I just want to make sure they know we do have a timer. That's a 2-minute timer running. So I gave the mayor the extra minute that was left over from the introduction. But we will hear next from Tiffany Scott.
Good afternoon, Chairman and members of the committee. Can you hear me? I just want to make sure I'm clear.
Yes, thank you.
All right, thank you. My name is Tiffany Scott. I'm a mother and parent, and also a peer recovery specialist and founder of the Maryland Peer Advisory Council. I ask today that you vote in favor of House Bill 396 for overdose prevention sites. Unintentional and fatal overdoses across the city and state of Maryland has caused a ripple effect in individuals who are in and seeking recovery. Families and communities are crippled. In 2019, 910 people in Baltimore, 910 lives in Baltimore City and families lost their lives to unintentional and fatal overdoses. In 2020, the Baltimore Sun, as a young lady reported, stated that 2,025 lives were lost as a result of unintentional and fatal overdoses. Of that number, 3 of those family members, my daughter and 2 other relatives, all under the age of 30, lost their lives. I would like to mention that they were all at home alone. I ask that you vote in favor of this bill to provide safe places for individuals who are utilizing substances to be supported with care and compassion and dignity and respect, with peer recovery specialists and harm reduction and others who are there to care and provide services for continuation of care for individuals who are seeking services. I ask that you vote in favor of this bill, and my name is Tiffany Scott. I am the parent, loved one, and family member of 3 lives who have lost their lives to unintentional overdoses, and also a resident of Baltimore City and a servant of the state of Maryland. Thank you.
Thank you very much, Ms. Scott, for your testimony, and we are so sorry for your loss. We appreciate you being here today. Next up is Rajani Gudlavaletti. Hope I got that pronunciation right.
Yeah, hello everyone. You can hear me okay?
Yes, thank you.
Okay, great, thank you. So hello everyone, I am Rajani Gudlavaletti. I am Director of Mobilization with Baltimore Harm Reduction Coalition. Since 2016, when we community-based harm reduction advocates began demanding that the state of Maryland authorize overdose prevention sites 5 years ago, we have lost over 7,300 Marylanders to toxic drug death and overdose. One of these beloved Marylanders was William Miller Sr., godfather of harm reduction in Baltimore. Sr. testified in front of you all for years, demanding you to authorize overdose prevention sites in our state. If you did as he asked, he would have been in a community-based OPS that day in October 2020. I've been a leader with the Bridges Coalition for Overdose Prevention Sites since our inception years ago. We are a coalition of over 30 statewide organizations who not only support this legislation, but whose staff and supporters have been educating and advocating in our communities across the state for over 4 years. I would not have had this job if it weren't for William Miller Sr., and I do not take that lightly. In recent years, I have had the privilege to visit a handful of operating overdose prevention sites in North America, and I'm happy to answer any questions about how they operate and how they would operate in Maryland. But for now, what I want to say is in my years of advocating and teaching people about OPS, I've watched leaders that have actually spoken against the overdose prevention sites. I've seen them shift. Once they sat down and had conversations and learned about how OPS work and could look, they have shifted gears, public officials. So I'm asking you, as our representatives, please take the time to talk to us. You have been sending the message that we as a state don't care about people who use drugs. Is that the message you want to send? Is sitting in these chairs more important than the lives that have been lost? That is what I need to ask you right now. So please, I urge you, please, pass this legislation finally. Don't make us come back year after year, because we will. Thank you so much for listening to me. Thank you.
Thank you very much for your testimony. Next is Ricky Morris Sr. Is Mr. Morris here?
Yes, excuse me. My name is Ricky Morris. I'm an outreach community coordinator for Baltimore Harm Reduction Coalition. I've been advocating for this bill for the last 5 years. Most of you probably heard of the losses I faced. My brother, how he was isolated, and my cousin, he had went home and people was around them that saved his life. And like she said, not only William Miller Sr., but I have buried at least 8 close members of the avenue that I support, that I grew up with, die. and they were very close. I watched people grow up and die, and I was part of a community where as though I could have been in that same boat. Right now, I'm back out here giving back and and saving lives because I had the opportunity to be here, but I could have been easily somebody that died. And is it worth losing their lives when it could be prevented? We jumped into action for the covert, like people losing lives, they gotta be saved. Why aren't people jumping to the same conclusion about overdoses? It sends a message that these people are not worth saving, and that's not true, because you can see where people turn their lives around and able to give back, such as myself, losing a brother, still using, didn't get it right until I was able to be around peers of myself, like myself, that understood what I've been through, and I could relate to, where I was able to be comfortable and start making changes. And that's what we need. That's what overdose prevention sites give us, a lot of peer support. Thank you.
Thank you very much, Mr. Morris, for your testimony. We appreciate seeing you back here again. Next up is Jessie Dunleavy.
Hello, can you see me?
Yes.
Yeah, okay, good. Thank you for this hearing. My name is Jessie Dunleavy. My son Paul died of a drug overdose in 2017. I loved and admired my son, and I know his death was preventable. Rather than shaming people who suffer with a substance use disorder, we need to prioritize public health and human rights. And overdose prevention sites do just that. They reduce overdose deaths, they reduce the spread of disease, they minimize the compounded misery of arrests, and they minimize drug use, and they maximize the likelihood of recovery. People are suffering, yet there's reluctance to implement proven strategies. Why? I get initial skepticism. On the surface, overdose prevention sites seem counterintuitive, but they work. So rather than blocking these life-saving initiatives, the job is to educate. We have to, it's an uphill battle since our long-term focus has been criminalization, but we just can't continue the failed practices of disempowering those most at risk, removing resources from them, isolating them, forcing the vulnerable into back alleys, exacerbating their mental and physical health. How is it that we're comfortable with jails and prisons where dehumanization is the norm, but uncomfortable with evidence-based healthcare that's proven to reduce deaths? Why? At the time of my son's death, local legislators rejected harm reduction out of hand, claiming it enabled drug use. This shocking mindset, one that doesn't bother with the facts, cost my son his life. These same people turned a blind eye to the fact that my son was incarcerated. And while he wasn't just mistreated, he was hungry, he was sexually abused. When he relapsed some years later, he died alone without a safe haven or any medical oversight. So you may ask why you would support this bill, but I have to ask why you would not. Thank you.
Thank you so much for your testimony. And again, I'm so terribly sorry for your loss. Do we have questions from the committee for this panel of proponents? I'm going to give you guys a second to raise your hands. Delegate Hill.
Thank you very much. I'd like to thank the sponsor, and I'm sure Delegate Moorhan would be very pleased to see this bill coming back and moving along. The question I have is, Philadelphia has been, I was hoping the mayor would be here, but it looks like he's gotten off. Philadelphia has been trying to get these safe injection sites. They initially had a district court ruling, I believe that was in their favor. Now they've got a third circuit court ruling that goes against and says this cannot be done because it's against federal law. So the question is, what is the plan? And why aren't we waiting until there's a judicial finding in favor of moving forward with safe houses?
I would love to answer that if that's okay.
Sure.
One of the reasons is because people are dying. So that's the number one reason, is that we have to prevent overdoses now. One different situation in Philadelphia is that they do not have the support of their state. The state of Pennsylvania has taken no action to support this large city that has been devastated by the drug war for decades and has been experiencing such high overdoses. So the city of Philadelphia had to push ahead to save their residents' lives. And in fact, we know that people from across Pennsylvania would have been going to Safe House, the soon to be inevitably overdose prevention site that will inevitably exist in Philly, but they didn't have Pennsylvania state support. And so in our organizing and conversations with Mayor Scott, I know that I respect and trust him so completely to know that he will help to follow through for Baltimore City to figure out how we'd be able to do it. But wouldn't it be so amazing if we didn't have to be scared of federal intervention to know that our state has our back? And so that is what we need, is for the state bill to be authorized so that we can get it supported. And also I would like to name very honestly, the statute that is the federal statute keeping OPS from being authorized is called the Crack House Statute from 1986. If that doesn't sound as outdated and racist as it is, then I would really encourage you to have some conversations with me about why it is so offensive that that is the federal legislation keeping us from saving lives.
Thank you.
Next question is from Delegate Charles.
Thank you, Madam Chair. My question is for the bill sponsor in regards to finding out what exactly and how do we categorize defining a high incidence of drug use location?
So in the bill on page 3, where it says that, it's up to the department and the Department of Health and the local department to be able to define that, and they will look at the numbers, right? I mean, we know, and the Department of Health keeps track of every overdose that we have in the 23 counties in Baltimore City, in the 24 jurisdictions. So they'll be able to, ascertain that fairly quickly. But what's really important, and because of the conversation that I had with you, Delegate, particularly, the bill says on page 5 that a program may not be located in an area zone residential use. We took that into consideration. And then the bill also says that the department may not approve more than 6 programs. And basically those programs, 2 will be located in urban areas, 2 in suburban areas, and 2 in rural areas. And it's not a mandate. It is up to basically, a program, a community-based organization that actually wants to do this. So again, because of the conversation we had with you, we defined it very specifically on page 2 that a community-based organization, again, is not a mandate. It's not in a residential area. It is up to whoever wants to do it. It could be a hospital, a clinic, a substance abuse treatment center, a medical office, a federally qualified health center, a mental health facility, a local health department, that wants to do it. It is up to them if they want to do it. And again, the department who keeps all these data will be able to take the application and in cooperation with the local health department, decide whether they would approve the application, whether it meets all the criteria in the bill.
Thank you, Madam Vice Chair.
My pleasure.
Excellent. The next question is from Delegate Johnson.
Thank you, Madam Chair, and thank you for bringing this bill. I know when those safe sites, that bill came to us before, I did a lot of research, and these seem to be work all over the world with great outcomes. So my question is, do you see us as a state being able to move forward with something like this, even though the feds are not on board, just like we did with the medical cannabis?
That's correct. And thank you for asking that question. We passed medical cannabis, which is against federal law. And we did it because of the science, because the science shows that it works and that it helps people that are sick. It helps them with their symptoms. 15 states have passed recreational, also cannabis bill, and it works. So I am asking the committee, the state of Maryland, to do the same here, because it is the right thing to do. And we have lost, every year we lose more than 2,000 people. And you know what happens, Delegate, is that they die in dark alleys in the bathrooms by themselves without any help. At least this way, they have a place to come where it will be supervised with doctors and nurses. And if they want referrals, they can seek referrals as well. And we're not providing the drugs. I mean, come on, we're not providing the drugs. They're using them. And we're just saying, come to a safe place where we can give you support. And we did it with medical cannabis. We need to do it for this because people are dying.
Thank you, Madam Chair, and thank you for bringing forward the bill.
Thank you, Delegate Johnson.
Delegate Bagnall.
Thank you, Madam Chair, and thank you for bringing this bill forward. I too did my due diligence when we had the bill before, and I know that the American Medical Association actually weighed in on the amicus brief in favor of Philadelphia for the lawsuit. So my question is, in terms of the liability for the providers, because there was even a story in the Washington Post about a secret facility that was doing this and they hadn't had a single overdose death because the providers were there. Would their liability just fall under their scope of practice as practitioners? We don't need to define it in the bill.
It doesn't need to be defined in the bill. It will fall under their scope of practice. And there are over 150 of these all over the world. And not one person has died. Not one person has died.
Thank you. Thank you, Madam Chair.
Absolutely. That looks like the last question from members of the committee on this panel. So we will move to a panel in opposition. Let us hear from Laura Bogley.
Good afternoon, Madam Chair and esteemed members of the committee. Thank you for the opportunity to speak with you today. I'm Laura Bogley and I serve as Legislative Director for Maryland Right to Life. On behalf of our members across the state, we oppose HB 396 as written, only to the extent that it will force Maryland taxpayers to promote and subsidize abortion and deprives the people the natural and constitutional rights to life, liberty, freedom of speech, and religion. This bill will require the Maryland Department of Health to provide access and referrals to reproductive health education and services, which will necessarily include abortion under Maryland law. While we agree that it is important for all pregnant women to receive quality prenatal care, we do not agree that abortion qualifies as health care or that the state should be referring vulnerable patients, especially those drug addicted, to abortion providers like Planned Parenthood. Pregnancy is not a disease, it is violence and brutality that systemically targets the poor and minority populations and ends the lives of unborn children through suction, dismemberment, or chemical poisoning. The fact that 85% of OBGYNs will not commit abortions is glaring evidence that abortion is not an essential part of women's health care. Abortion exposes women to both physical and psychological complications and increases maternal mortality in subsequent pregnancies. In the case of women experiencing addiction, it's highly questionable whether they can even provide informed consent necessary for an abortion. The state programs commit significant taxpayer funds to Planned Parenthood for prenatal services, but Planned Parenthood is not a significant provider for prenatal care. Planned Parenthood's business model is built on profiting from abortion. Planned Parenthood commits 41 abortions for every one prenatal care service and 133 abortions for every adoption referral. Planned Parenthood provides no pediatric care. In their annual report, Planned Parenthood reports that they committed 354,871 abortions, nearly an all-time high, while in stark contrast, they report that prenatal care and adoption referrals have declined by 75%. 80% of Americans polled favor laws that protect both the lives of women and unborn children. Public funds should be prioritized to fund health and family planning services, which have the objective of saving the lives of both mothers and children, including programs for improving maternal health and birth and delivery outcomes, well baby care, parenting classes, foster care reform, and affordable adoption programs. For these reasons, we respectfully urge you to amend this bill to preserve the good purposes of the bill or otherwise issue an unfavorable report. Thank you for your consideration.
Thank you. Next up is James Strother. Do we have Mr. Strother in the committee today?
I don't think he'll be joining us.
Okay, well then that concludes the opposition panel. Do we have any questions from members of the committee? I see Delegate Charles.
Thank you, Madam Chair. You know, I'm not a fan of the bill, but I will say I'm a little taken back because I don't understand what Ms. Laura Bogley's conversation on abortion has to do with this bill at all. Can you explain that a little bit more in detail? Because I am kind of lost. I don't understand what abortion has to do with these particular sites.
Ms. Bogley, would you like to answer that question? I think she may have hopped off. I see her name, but not her face. I guess we'll try and follow up and get that answered in written form, maybe, unless we see her pop back up. I guess we will conclude the hearing on House Bill 396. Yes, no more questions. Good. So that concludes the hearing on House Bill 396, and we will move to House Bill 470, Delegate Ruth, Public Health Commission on Universal Health Care. Delegate Ruth. I think she's just joining us. I see her. Delegate Ruth, are you here to present your bill?
I am. Are you ready for me?
Yes, we are. Thank you.
Great. Thank you so much. Delegate Sheila Ruth, for the record, presenting House Bill 470. Thank you, Madam Chair and members of the committee for this opportunity. HB 470 establishes a commission on universal health care to study the creation of a statewide single-payer universal health care system and develop a plan. The Affordable Care Act made progress in closing the health care coverage gap. However, many people still remain uninsured. 355,000 Marylanders were uninsured as of March 2019, and that was before the pandemic. And there's also an infographic in my testimony, written testimony, that shows the disparities in the uninsured as well. Around 900,000 Marylanders filed for unemployment during the first year of COVID-19, and likely many of those lost employer-based health insurance. Maryland opened special pandemic enrollment on the health benefit exchange, but the costs of the exchange are out of reach for many. Some of the cheapest plans have deductibles of $6,000 or more, meaning that they can't be used except for catastrophic health events. And even then, a person may delay care due to inability to afford out-of-pocket expenses. No state has yet enacted a statewide universal health care plan, but there are good reasons to be optimistic that it can be done, and Maryland has the opportunity to be a leader. Canada first enacted universal health care in the province of Saskatchewan. The Saskatchewan model was later adopted nationally, so Canada is a model of adopting it first at the province level and then moving up to the national level. US healthcare has some unique factors that will make statewide single-payer healthcare challenging, including Medicare, Medicaid, federal employee health programs, and workers' compensation. However, much work has already been done in these areas nationally and in other states, and there are reasons to believe most of these barriers can be overcome. The Affordable Care Act allows for states to apply for a state innovation waiver of all ACA requirements as long as the state plan provides at least as much coverage as the ACA and doesn't impose extra costs on the federal government. These requirements should be easily achievable with a single-payer universal healthcare system due to administrative cost savings and market share savings. Medicare currently only spends about 2% on administrative costs compared to private insurance with 12%. So Medicare, the closest thing that we have to a single-payer healthcare system in Maryland right now, in the US right now, has much lower administrative costs. The Congressional Budget Office released an analysis of Medicare for All in December, showing it would reduce healthcare costs in 4 out of 5 scenarios. The CBO numbers are national values, so can't be applied directly, but they show that dramatic cost savings are possible. A December 2019 analysis of Maine's proposed universal healthcare system shows cost savings for most individuals and employers, including state, local, and municipal government employers. Similarly, a 2015 analysis of New York's proposed healthcare system showed that 98% of New York households would spend less on healthcare under the plan. The Commission of Universal Healthcare created in this bill would determine the funding, operating structure, and health benefit package, as well as how to incorporate Medicare, Medicaid, and the exchange, state, federal, and municipal employee healthcare, and how to incorporate employee healthcare for private employers that choose to participate. This bill provides a path to universal healthcare, which in the long run will save the state, individuals, local government, and businesses money, while ensuring that all Marylanders have healthcare when and where they need it. I ask a favorable report for HB 470. And if I could see the rest of my time, if Christy Fogel is on.
Absolutely.
Thank
So
you.
we will call up, thank you for your testimony. We'll call up Christy Fogel and we will give her 3 minutes and 4 seconds or something roughly like that. Christy.
Hi, thank you. Can you hear me?
Yes.
Okay. My name is Christy Fogel. I'm an emergency medicine physician assistant, and I'm also founder of the Maryland Progressive Healthcare Coalition. I'm a resident of Baltimore County, and I've been practicing emergency medicine in and around the Baltimore region for the past 8 years. As a frontline healthcare provider, I speak on behalf of the patients insured by the private for-profit health insurance companies who many consider to be covered. As an ED provider, I see patients like this every single day. I've seen diabetics who come into the ER in crisis with blood sugars in the thousands because they were forced to ration their insulin. I've seen cancer patients who avoided their chemotherapy because they didn't want to bankrupt their family. From these patients, ED providers like myself frequently hear statements like, how much is this going to cost? My insurance won't cover this. I can't afford this bill. I've had many of these patients get up and walk out of the emergency department against medical advice when I attempt to admit them to the hospital. In one such case, a patient with appendicitis who needed emergency surgery left because, and I quote, I won't be able to afford this, I'll take my chances. As you can imagine, this is not what I went to school for. This is both frustrating and heartbreaking to witness as a healthcare provider who took an oath to care for my patients to the best of my clinical ability. I'd like to make this statement for the record. I don't care who you are. I don't care where you trained. It is impossible to practice to the best of your clinical ability in a for-profit health insurance driven system. Prior to the COVID-19 pandemic, 80 million people, or nearly half of all adults under 65, were uninsured or underinsured in this country. In Maryland, with the ACA fully expanded, that number equated to over 347,000 people still left uninsured. Due to the COVID-19 pandemic, over 27 million more individuals nationwide have lost their employer-sponsored health insurance. This committee must address the growing crisis that faces Maryland patients, which has worsened with the COVID-19 pandemic. Maryland patients need the General Assembly to step forward to ensure that they stop falling through the cracks of a broken for-profit healthcare system that has been complicated by multi-payer administrative costs and an emphasis on profit over patient care. HB 470, if enacted, will take an important step towards providing universal coverage that Maryland patients desperately need by establishing a commission on universal health care, which would develop a plan for the state to establish a universal single-payer health care program. Marylanders deserve a universal single-payer system that focuses on their care without concern for middleman profiteering by the insurance industry, who, let's be clear, only goal is to maximize profits by denying care. On behalf of my patients and our community, I asked you to pass this measure with a favorable recommendation because Marylanders deserve the basic right of health care. Thank you for your consideration.
Thank you very much for your testimony. Next, we have Michelle Gregory.
Thank you very much. My name is Michelle Gregory, and I am the council member for District 4 for the city of Salisbury, Maryland. My family has had more than our fair share of medical emergencies. We've been fortunate enough that my husband's health employer provides a means to purchase health insurance. In recent years, however, my husband's health has taken some big hits, and that will be with him for the rest of his life. These debilitating health issues have been a struggle, as has the knowledge that if he were to stop working because of his disabilities, we would lose our health coverage for the entire family, each of whom has their own disabilities and relies on frequent doctor or specialist visits and medications. I represent a district filled with people facing these same issues. Many work jobs that do not even offer health insurance, and when they do, the coverage costs are out of reach for most. Between plan premiums that run in the hundreds of dollars to deductibles, some as much as $10,000, it's still far too out of reach for too many. This bill would also help cut municipal costs. Salisbury offers employee health coverage, and if the state were to create a universal health coverage plan, that burden would be lifted from our city to the tune of $3.7 million a year. Imagine what we could do with that. And this would help many other municipalities around the state. A single payer system would resolve the healthcare and employment barrier and produce a savings of about 18%. A single payer system would shrink the net healthcare spending for middle income families between 2.6 to 9.1%. Save employers with fewer than 500 employees between 5.7 and 22% in healthcare costs as a share of payroll. Benefit small businesses who are already providing healthcare for their workers, and target low-income communities and reduce challenges faced by minorities. If we've learned anything during this pandemic, it's that healthcare is a human right, and we as community leaders are tasked with providing care for all people. Creating this commission is a moral imperative for our state. I ask that you vote favorably for this.
Thank you very much for your testimony. And finally, we have Amber Green.
Amber unfortunately isn't able to be with us today.
Okay, well, that seems to be it for our panel of support. Do we have questions from the committee? I'll give you guys a second to raise your hands. Delegate Bagnall.
Thank you, Madam Chair, and thank you, Delegate Ruth, for bringing this bill. I just wanted to circle back and give you an opportunity to respond to the fiscal note, because as I understand, this bill speaks to creating a commission. So I'm a little flummoxed at the price tag, and I wanted to give you an opportunity to address that if you have some clarity on why it comes with such a high price.
Thank you for the question, Delegate. And yes, frankly, I was flummoxed too when I saw the fiscal note. We're talking a commission, and the commission is not paid. They will require some staffing, probably some consultants to be able to do their work. But the idea that they need $3 million in consultants is ridiculous. I did some research into what costs. I think of this commission as being similar to the Kerwin Commission, which also dealt with a complex subject matter of education and developing what became the blueprint for education that we just passed. The Kerwin Commission over from 2017 to 2020 hired 3 consultants at a cost of $256,000. So, I could understand maybe this might be a little more complex, although the Kerwin Commission, did deal with a complex topic. But the idea that it's 10 times as much as the cost of the Kerwin Commission is a little bit ridiculous. Thank you.
Thank you. Thank you, Madam Chair.
Absolutely. Seeing no more questions, that concludes the hearing on House Bill 470. Thanks for being here. We will move on to House Bill 534, Delegate Acevedo, Public Health, Maryland, Healthy Maryland Program Establishment. Is Delegate Acevedo here to present his bill?
I've called and emailed his office and he's not with us yet, so I think we should probably come back to him.
Or we can move on to Christy Vogel, and then we'll hear from Zachary Berger, and perhaps Delegate Acevedo will be able to join us by then. Ms. Vogel, can you introduce the bill for us?
So I don't think that I can properly introduce the bill. The only thing that I could probably do is just add some extra testimony to that bill, but I would definitely defer to Delegate Acevedo for that.
Well, since he is not here, why don't you tell us how you add whatever you want, or is Zachary Berger here?
He's not here either. I've emailed him also.
All right. Well, we will move this bill, I guess, to the bottom of our agenda, unless we haven't heard anything from Delegate Acevedo.
I spoke with his office like 10 minutes ago.
Ms. Vogel, why don't you give us your testimony, and then we will leave the hearing open in case Delegate Acevedo returns. But we'll have had your testimony so that at least if he doesn't, we will have heard something on the bill.
Sure. I mean, so the only thing that I would add in relation to this bill, and obviously I support both bills, is that this bill would take critical steps towards creating health equity in Maryland by establishing a comprehensive universal single-payer healthcare program and creating and establishing a healthcare cost control system for that program. The other big piece of this bill that I support is eliminating any cost sharing or insurance premium obligations to residents of the state, and also enabling healthcare providers like myself to collectively negotiate within that single payer program. So they're the basics of why I support it, aside from why I support the other bill as well.
Wonderful, thank you. That was great testimony. Do we have any questions for Ms. Fogel from the committee? I'm not seeing any hands.
Wait a minute.
Yes, Delegate Peña-Menech.
Delegate Acevedo is signing in right now.
Perfect timing. Excellent. Thank you for the heads up. And we will wait for him. I see him signing on. So Delegate Acevedo, we have already heard from Ms. Fogel, but we would love for you to be able to present House Bill 534.
Thank you very much, Madam Chair. Good afternoon, everyone, and apologies. I appreciate folks notifying me I was in committee. For the record, Delegate Gabriel Acevedo here to present House Bill 534, the Healthy Maryland Act. And colleagues, this bill is a reintroduction, so I won't speak too long. But in essence, what the bill does is creates a single payer Medicare for all system right here in the state of Maryland. And the reason why this is particularly important, especially as we are coming out of a global pandemic, and we've seen the numbers of uninsured Marylanders go from a little over 450,000 Marylanders before the pandemic to now over 500,000 and growing. And the reason being is because we're seeing why tying health insurance to employment was and still is a bad idea. And so I think we need to get to the point where we're providing every person in our state with comprehensive health coverage. And I think that is something that we can do and lead at the state level. I'll point to our neighbors in the North, Canada, that has a universal healthcare system. They got there because it started at the provincial level, and it started with provinces leading on providing universal healthcare. And I think in the United States, we can do that at the state level, and Maryland has an opportunity to lead. We already have the foundations for that with an all-payer system, with the necessary components to be able to implement a single-payer system. But just to also point out that we already spend 1/3 of our state's budget on healthcare. And that number is projected to grow according to the fiscal and policy note, if folks take a look at it over the years. It's really time that we look at a policy that covers all Marylanders, so that regardless of where you work, your employment status, socioeconomic status, that you have health coverage that's covered, and that the Healthy Maryland program is a unit of state government, and we can ensure that everyone else is taken care of. I'll say briefly and conclude that in the fiscal and policy note, you will see on the small business effect meaningful. And the reason why that's particularly important is because the Small Business Administration for the small business owners and entrepreneurs on this committee and in the assembly surveys small business owners across the United States every so often. And among the issues that continues to come up as a concern for small business owners and entrepreneurs is the cost of providing health insurance to employees. The cost of providing health insurance to employees. And so if we truly care about small businesses and entrepreneurs and seeing small businesses grow and thrive, which I support and I know you all share, then we need to look at healthcare coverage at the state level and ensure that we're providing coverage to everyone. And with that, I thank you all very much, and I urge a favorable report from this committee. Thank you, Madam Chair.
Thank you very much. Do we have questions for the sponsor of this bill? I'll give you a second to raise your hands. Perfect. Seeing no questions, that concludes the hearing on House Bill 534. Thank you so much.
Thank you very much.
All right, we are moving right along to House Bill 416, which is Delegate Belcastro, Healthcare Facilities, Assisted Living Programs, Memory Care, and Alzheimer's Disease Unit Regulations. Delegate Belcastro.
Thank you, Madam Chair. I like the titles of my bills this year to be very lengthy and long. And also, this is my last bill of the session, so it's an honor to be before you today. So thank you, Madam Chair, and members of the Health and Government Operations Committee for allowing me the opportunity to be before you today. For the record, I'm Delegate Lisa Belcastro presenting House Bill 416, Healthcare Facilities, Assisted Living Programs, Memory Care, and Alzheimer's Disease Unit Regulations. So for the past year, I've had the honor of serving on the Oversight Committee for Quality of Care in Nursing Homes and Assisted Living Facilities, alongside my friend and committee colleague, Delegate Kerr. And as a committee, we've been very active over the last year. At times, we've met as much as 3 times per month. And through our work, we've revealed that there's a lot of frustrations surrounding assisted living facilities when it comes to consumers, their families, and the groups that represent them. These frustrations, they've been echoed, and we hear about them in our offices through constituent emails, and also echoed in articles that have been within the Washington Post and in Maryland Matters. But I didn't just learn about the frustrations surrounding assisted living in Maryland. I've also learned about tangible ways that we can act right here and now to make some of the needed changes, and this bill seeks to do just that. The Office of Healthcare Quality already has started the process of updating the assisted living regulations in Maryland, and that's great. The issue is that the draft form of the regulations have been sitting on OHCQ's website untouched since 2016. This draft has some great provisions in it, and it would directly address a number of the concerns that have been raised by consumers, their families, and advocacy groups, specifically around memory care and Alzheimer's disease units. So this bill, it's evolved since it was first introduced, and it's been conformed to the version that passed unanimously out of the Senate. If you're interested in reviewing the amendments, I've uploaded them for you in the testimony section of your floor system, so you can access them there. The major point of this bill is that it would force the Maryland Department of Health to adopt regulations for assisted living programs by December 1, 2022. This bill also ensures that important provisions surrounding memory care and Alzheimer's disease units are included in the regulations, and those provisions include annual training requirements that must be completed by staff assigned to these units, and putting in place a direct care staff standard adequate to meet the needs of the residents that reside in memory care units. So I mentioned earlier that this bill, that the bill is presented today, passed the Senate Finance Committee and the full Senate unanimously. So at the time of the hearing in the Senate, the industry stakeholders submitted unfavorable testimony to this bill. Today, you'll see that they've submitted testimony that is favorable with amendments. And I believe that this demonstrates our willingness to work with the industry on the bill. And in recent days, we've had very productive conversations with the industry and feel confident that we can get to a place of agreement so this bill can finally move forward. In conclusion, I just want to say that MDH is required by law to update the assisted living regulations every 8 years. However, due to a waiver, the regulations have not been updated since 2008. And for context, I just graduated high school in 2008, so it's been a while. Because of the waiver that was issued, the regulations are not due again to be updated until 2025. Considering that the regulations have been sitting in draft form since 2016, it's vitally important that we pass this bill and give the department a friendly push to finalize these regulations and ensure that the important provisions improving memory care and Alzheimer's disease units are included. So thank you again to the committee for allowing me to present HB 416. We respectfully ask for your favorable report. And with that, I want to hand it over to my panel who will provide some important insight on the necessity of the bill. Thank you.
Thank you. Now, Delegate Belcastro, I have 2 panels, a favorable panel and a favorable with amendment panel. So I'm going to call the favorable panel, that's the panel you just referred to, right? Ali Anderson and Tammy Bresnahan. And
yes, that would be great. Thank you so much, Delegate Kelly.
So let's hear from Ali Anderson.
Good afternoon. Thank you, Chairman and members of this committee. My name is Allie Andreessen, and I am a staff attorney with Maryland Legal Aid Long-Term Care Assistance Project. I assist, advise, and represent older adults and persons with disabilities receiving long-term care, both in the community and in long-term care residences, such as assisted living facilities. Maryland Legal Aid supports this bill because it seeks to establish minimum standards for specialized memory care units in assisted living facilities. Under the current regulatory framework, which, as has been said, hasn't been updated in over a decade, assisted living facilities seeking to establish a memory care unit are required to disclose information relating to staffing, training, the services they offer, et cetera, in their initial license application. This is a mere disclosure requirement, and the information provided to the Department of Health is subjectively evaluated. Currently, there is no specific standard a facility must meet in order to establish a memory care unit. Nursing homes, comparatively, have a substantially higher burden for establishing a specialized unit, such as a memory care unit within their facility. These nursing home memory care unit regulations require involving families in the resident's care, developing an evolving resident center plan, and having a quality assurance plan in place. More broadly, nursing home residents are provided more protection and due process rights under both state and federal law. The residents of assisted living facility memory care units are often living with the same disorienting, degenerative medical conditions as their nursing home counterparts. They are a vulnerable patient population that need the added protections this bill seeks to enact. The COVID-19 pandemic has forced residents to rely on assisted living facility staff now more than ever. For almost a full year, visitation has been prohibited or severely limited. Family and friends are unable to visit and supplement their loved ones' care and provide mental stimulation, and they cannot enter a facility to advocate for their loved ones. Residents of memory care units are particularly affected by the reality given the nature of their medical conditions. Memory care units and assisted living facilities are specialized unit, and this bill seeks to establish specialized standards to reflect that. House Bill 416 ensures that these vulnerable residents receive the care and protection they need. Thank you for the opportunity to speak on this important bill.
Thank you very much for your testimony. Next is Tammy Bresnahan.
Hi, good afternoon, Madam Chair and members of the Health and Government Operations Committee. I'm Tammy Bresnahan, and I'm the Director of Advocacy for AARP Maryland. It's a pleasure to be with all of you today, as I don't get to be in here that often. I will be brief, but our founder, Ethel Percy Andrus, who helped pass Medicare in 1965, had a quote. She said, "What I do for all." And sometimes folks think, well, what are you doing in the long-term care space? And again, our population is 50 and over. And so one of the things that we want to make sure is that they age in place, that they age properly, that they age where they need to age. And we understand that assisted living is a very important part of the long-term care spectrum, and we respect that. I will like to bring your attention, I submitted testimony, and you can read the full background. But in 2005, the Maryland Office of Healthcare Quality, in its report entitled Maryland's Assisted Living Evaluation, they noted, for over a decade or more, it has been widely known in the industry that the residents in assisted living facilities consistently present acuity levels that were previously only seen among nursing home residents. In 2005, up to 2/3 of the residents in assisted living programs have moderate to severe dementia, and less than half receive adequate treatment for this condition, which I believe gave impetus for the drafting of the 2016 regulations that Delegate Belcastro referenced. Given the enormous variability in regulations and services provided by assisted living, consumers are unsure what to expect in different types of facilities and communities they call home. While skilled nursing facilities are fairly well defined and regulated both at the state and federal level, there is more levels of service depending on what authorized or required by the state, especially in assisted living. AARP believes that policymakers like you all should pass laws that implement various approaches to promoting service quality and protecting the rights of consumers. That we ask you for a favorable report, and we thank Delegate Belcastro for introducing this important piece of legislation. Thank you.
Thank you. Next, we'll hear from Aileen Klein.
Thank you very much. My name is Aileen Klein, and I'm here today in support of HB 416 because of my mother, who in 2013 began living in a Montgomery County assisted living facility. And then in 2017, she was transferred to their memory care floor. We are very fortunate that she is able to afford such an excellent facility where we pay over $10,000 a month for specialized care. People with dementia need a great deal of care and protection due to their level of mental impairment, which can vary from day to day or even hour to hour. Sometimes they may seem fluid and a minute later confused and disoriented. My mother has forgotten how to do many things, including answering her phone. The ringing sound is now meaningless to her. Similarly, the pendant alarm that she wore when she first arrived at the assisted living facility is no longer useful. As a result, if she forgets she needs help going to the bathroom in the middle of the night and gets out of bed and falls, she has no means of getting help. As we age, even our voices become weaker. So when she cries out, no one's able to hear her. This could result in painful hours on the floor for her unattended. I chose to move my mom into an assisted living facility that had both assisted living and memory care because they have many more options for everyday interactions and activities as compared with a facility with solely memory care. My mom loves Jeopardy, word games, and even discussion groups with assisted living facility residents. On some days, she can only listen, but many times she can participate also. The cost of memory care is extraordinary, yet the requirements for memory care units are more limited, as neither the legislature nor the health department have required any specific differences for memory care units within assisted living facilities. In closing, I urge you to support Bill 416, HB 416, so that we can get an update to assisted living regulations and one that ensures there are more special regulations for memory care residents. Thank you very much.
Thank you very much for your testimony. It's nice to see you. Do we have questions for this panel? I'm giving the committee just a second to raise their hands. If we don't have any questions, we'll move on to the favorable with amendments panel. Wonderful. Let's move on. Let's hear from Rachel Faulkner.
Delegate Kelly, I'm so sorry to interrupt you. I think Delegate Hill's hand went up. I'm sorry.
Okay, Delegate Hill.
So I just want to clarify, the panel's coming up, you're not going to get a chance. The amendments that they're going to offer are the ones the Senate already took, or there are some additional amendments to what the Senate bill came out with?
So today I am concurring the bill that came out of the Senate with sponsor amendments, and those sponsor amendments can be found. I uploaded them into your testimony. So you can find, so what came out of the Senate is what I've presented to you today.
And that's consistent with what the next panel will be asking?
No, I believe there's going to be additional amendments today.
All right, thank you.
Yep, thank you.
And just a follow up to Delegate Hill's question, Delegate Belcastro. So in addition to the Senate version of the bill, which you're conforming and presenting to us, these amendments we're about to hear about, are those amendments that you support, or you haven't quite, you need some more time to work on?
Thank you for the question. I know it's a little confusing because there are a couple of amendments coming through. So I've had great conversations with Ms. Kaufman over the last couple of days. And for the most part, there might be one question, but for the most part, what she's going to present today, I'm in support with. And I think through some more dialogue and clarification, I think we'll get to that consensus.
Excellent. Thank you very much. Let's move on and hear from Rachel Faulkner.
Good afternoon, Madam Chair, members of the committee. Rachel Faulkner here with the Maryland chapter of the National Association of Social Workers with support with amendments for House Bill 416. I apologize for not having written testimony. This is one of those moments during our virtual session where being able to submit testimony the morning of would have been better than 2 days prior. So I apologize and can certainly put something in writing after this if you'd like. The Social Workers, National Association of Social Workers is in strong support of having standards for memory care units and regulations for assisted living programs. Social workers have a unique role in providing case management and long-term care facilities and programs. And in this role, they work to assist individuals and their families and caregivers find appropriate residential programs. As you know from working on other issues related to assisted living, there is a lot of variability in housing programs, and it can be very difficult for families to identify appropriate places, particularly when they're looking for a specialized unit like memory care. And they can travel the state and look at lots of different units before they find something that meets their needs. And part of that is because of the variability among the standards that different placements have. One of the things that I would say is the fiscal note references that the 2016 regulations were finalized. It's my understanding that they were never finalized and that they were never put out for public comment in the Maryland Register. We would prefer that there be a stakeholder process to ensure that those regulations from 2016 are able to be revised. Some of the provisions in them may no longer be applicable and may be in conflict with other laws that we've passed since then. We're also concerned that the language in Section 2 of the Senate cross-file would not allow for any additional changes from the 2016 draft, with the exception of memory care. So even if we found a flaw in the 2016 rule, that wouldn't be allowed. And very last, we would prefer a date that's tied to after the pandemic to allow programs to kind of normalize or stabilize after the pandemic, then have a date set for 2022. Thank you.
Thank you very much. Let's hear next from Eric Colchamiro.
Chair Kelly and Vice Chair Pena-Melnick, Eric Colchamiro, Director of Government Affairs for the Alzheimer's Association in Maryland, and here today to ask for your support of HB 416 as amended to parallel its cross-file, SB 204. This legislation requires a long overdue update of assisted living facility regulations and puts forward requirements solely for the state's 88 special care units, which house some of our most vulnerable Marylanders with Alzheimer's or other forms of dementia. If you look at the 2015 draft assisted living facility regulations, you will see that OHCQ put forward additional protections for these memory care units, including a new role of a memory care coordinator, a second section on memory care protections, and a third section on added protections for memory care units. OHCQ maintained these provisions in their 2016 second draft, despite industry objections to each of them. They recognized the need for added protections for memory care. Unfortunately, these protections were never codified into law, and without legislation, or if we open up these regulations fully again, they can be negotiated out. I would ask the committee in its consideration of HB 416 to preserve this bill's intent and focus as amended to parallel SB 204. Training for dementia must be addressed as dementia-specific training hours. Training requirements must be not just for employees, but also for contractual staff. Replacing SB 204's staffing standard with alternative language moves us further away from OHCQ's goal of a staff to patient ratio that they outlined in their 2016 second draft. And lastly, as SB 204 noted, we must finalize and move forward with these regulations in a timely fashion. In closing, we must put forward the right updated framework for assisted living facilities into place in a timely fashion with a concrete end date which protects seniors with Alzheimer's and dementia. I urge a favorable report on this legislation as amended.
Just waiting for the ding. Thank you, Mr. Colchamiro. Just for clarification for the committee's understanding, so you're saying you want to conform with SB 204, which is really in line with the favorable panel we heard before, as opposed to the other amendments we're hearing about in this favorable with amendments. So the amendments you're referring to are those that would conform it to SB 204.
Correct.
Excellent. Thank you very much. Next up is Dana Kaufman.
Thank you very much, Chair Kelly, members of the House and Health and Government Operations Committee. For the record, my name is Dana Kaufman. I'm here today on behalf of Lifespan Network. You do have my written testimony, which does offer an alternative amendment. I want to make two comments. In the uncodified language, Ms. Faulkner was correct. We are very concerned that the language would require the 2016 draft to be adopted as is, except for the memory care unit. And there were provisions that were contained in the 2016 draft regarding memory care units. However, as Ms. Faulkner did point out, that draft, which I was very much involved with, every stakeholder meeting that went on for a couple years, was only considered a draft. And there were still many provisions that needed to get worked out. And like I said, there was memory care unit provisions in there, and Lifespan did express our concern about them. One of those concerns was that the unit would have required a coordinator to have 30 hours and a worker to have 20 hours of training annually. And our concern was that we did not want to price those units out of the market. We were also concerned that the training could only be done by a nationally recognized organization. And we felt that Maryland companies should also be able to offer that. But those are some of the issues that may need to be discussed, as many others. But more importantly, they're 5 years old now. So there is probably many issues that need to be examined over the last 5 years, including looking through the lens of COVID. So the draft amendment that you have, that's part of my testimony, has the 2016 as a starting point, because I don't think anybody really wants to create the wheel on every provision. The other amendment does maintain the memory care language. It just places it in a different section of the law that we think is more appropriate. The only other point that I would like to make, if I could, is I know it's very easy to compare assisted livings to nursing homes, but for the most part, nursing homes are all pretty much the same size. Where assisted livings, we're dealing with facilities that have 2 residents to 200 residents, all in one reg. So that is why it does take a different approach when you're trying to regulate a one-size-fits-all. So we do appreciate Delegate Balcastro working with us, very much so. And we hope that we can get to a point where we can pass this bill. And like I said, we do believe that 2016 reg should be the starting point, not the final point. Thank you very much.
Thank you. Next up is Aaron Greenfield.
Good afternoon, Madam Chair, members of the committee. Aaron Greenfield here on behalf of Leading Age Maryland in support with amendments on House Bill 416. You have our joint statement in the record with Lifespan. With our suggested amendments, which we thought were friendly amendments, we believe that we strike an important balance between the need to finalize these AL regs as noted in the uncodified language in our amendment and to convene a stakeholder group, and at the same time address the need for training hours and topic content for those employees who provide care in these Alzheimer units in the assisted living facilities. So for those reasons, I'll be brief. We suggest and respectfully request a favorable with these amendments and happy to answer any questions.
Thank you very much. Do we have questions from the committee? I'm going to be real slow because I know I missed Delegate Hill last time. Delegate Hill.
I know I'm hard to miss. Anyway, thank you. First of all, Delegate Balcastro, thank you so much for your work and for bringing this bill. Ms. Kaufman, we had earlier legislation that talked about dementia training for direct care workers, I think in residential homes and some other things. I think Delegate Sample Hughes had, I think, 141. The dementia training that is being mandated to be designed here, could that be the same? Is there some overlap here? Are we talking about totally different dementia training than the bill we've already passed through?
Well, first of all, the bill that you passed through dealt with residential service agencies, which is providing the in-home care. So while there could be some overlap on subject, I do think given the differences in the setting, that training needs to be done differently and that has to be more specialized for each setting. But I will point out that the assisted living managers have an 80-hour course that they must take, and 12 hours of that 80 hours is on Alzheimer's and dementia care training. So I think that there just needs to be, I think you could probably pull some of that, but this will be, depending on the hours, its own training topic.
So it might be 2 different tracks, and the development of a curriculum in this bill could be based on the curriculum that's already being used.
Correct. Okay. And probably with some updates.
Thank you.
Excellent. I'm looking for Any further questions? But I see no further questions. One last chance. Anybody? Wonderful. Well, that is both panels. So with that, we conclude the hearing on House Bill 416. Thank you very much. And I just want to make sure the committee has a time check here. It's 2:53. We have 1, 2, 3, 4, 5, 6, 7 more bills left. So let's keep that in mind. We will try to be efficient. Actually, 6 more bills left. It's better than I thought. Delegate Cullison, you are next. House Bill 1032, Health Occupations, Licensed Direct Entry Midwives, Previous Cesarean Section. Delegate Cullison.
Thank you very much, Madam Chair. Thank you, Madam Chairman, Madam Vice Chairman, and members of the committee for the opportunity to present this bill. This bill would narrowly expand the scope of practice for licensed direct entry midwives, and we'll call them LDEMs, to include low-risk women who have had a previous cesarean section under some very, very strict restrictions. This is referred to vaginal birth after cesarean or VBAC. Yeah, I have to admit, I am a convert to the value of and importance of midwives. And when we decided in 2015 as a body to allow licensed direct entry midwives to practice in our state, we did so because we really appreciated their very highly patient-centered model of care. And we had enough data, sufficient data from other states to demonstrate the safety and effectiveness of their practice. And our belief in them has borne out over the last 4 years as the incidence of bad outcomes is almost nil. Given the positive experience that we've had, we'd like to now ask that LDEMs be allowed to practice with women who have had a previous cesarean. But here are the conditions, and you're going to hear these probably several times because we want you to understand how important these conditions are. The woman's only had one previous cesarean that's a low-lying transfer incision, which is at a low risk for rupture. The previous C-section was at least 18 months prior to the due date. And most importantly, the LDEM is mandated to consult with another healthcare provider, explicitly an obstetrician or a certified nurse midwife. And of course, all the protections around informed consent and transfer requirements would still apply to this. I know that there's some concerns about liability, legal liability in these situations. So I just want to be clear. The LDEM assumes the legal liability for the care they provide, including the patients that require consultation with another medical practitioner. With regard to the liability associated with the consulting practitioner, they're going to consult with folks who already have experience and knowledge in VBACs and understand the conditions under which there is the least risk. So there's really no increased risk to them. If something should happen and there needs to be a transfer to a hospital, then frankly, the practitioners at the hospital assume the risk for the service they provide at the hospital. So their liability is limited to what they receive at the hospital. It's kind of like if I had a car accident and I went to the hospital, it's not the person who hit me in the car that's liable. It's for my healthcare, it's now the doctor who's serving me. So that's how the liability chain works. It's important to keep in mind that this is about giving women the ability to choose how they want to have their children. And actually in the letter from the Department of Health, it said, in making the decision, the women has to look at several different things. First of all, what are their personal preference? What's their obstetric history? And the risks and benefits of attempting to have a vaginal birth versus a predetermined cesarean birth. So this is not a decision that's being made lightly, and women, and we're letting them make this decision based on complete information from practitioners. Passage of this bill would put Maryland in line with 23 other states that allow them. They have the similar restrictions to what we're putting into this bill. And we hope that you'll hear a little bit more about what the other states are doing. I'm very proud to have the support of the Women's Caucus on this bill. And I want to thank you for your consideration. And I'll turn my last minute over to Caitlin McDonough. Thank you, Madam Chair.
Absolutely. Thank you very much. Let's hear from Caitlin McDonough, and you'll have 3 minutes and 11 seconds or so.
Thank you, Madam Chair, and good afternoon, Chair Pendergrass, Chair Kelly, and members of the committee. My name is Caitlin McDonough, and I'm representing two entities today. One is the Association of Independent Midwives of Maryland, which is the trade organization for out-of-institution maternal health practitioners in the state. AIM's membership includes both licensed direct entry midwives, which are the subject of this bill, and certified nurse midwives. And I also am representing Maryland Families for Safe Birth, which is a statewide patient advocacy organization who seek increased access and equity in maternal health care in Maryland. And I'll take this opportunity to quickly thank Delegate Cullison for working with us on this bill and for the committee's consideration. I won't go into, I think Delegate Cullison did a good job describing the bill. It's a pretty short, simple bill as far as terminology. And much shorter than our licensure bill that I'm going to go into that passed in 2015. But one thing I will note is our current Practice Act, or the LDM's current Practice Act, has two extensive lists of conditions for patients. And on one of those lists, if you have that condition, an LDM is prohibited from providing services to you. Then there is a secondary list that if you have one of those conditions or you meet one of those requirements, that they can only provide services if they consult with another practitioner. And I believe in the current law that is specified as a physician, a certified nurse midwife, or a nurse practitioner. Generally, we are working with CNMs or obstetricians, probably CNMs most likely. So what this bill does is takes this limited population who've had the previous C-section that Delegate Cullison described and moves it from the prohibited list to the consult list, along with other conditions which we think have a similar risk level, potentially higher given the low risk population in this bill. And for those of you who weren't on the committee in 2015, we went through we passed, after years of working in stakeholder groups and work with the committee and the Board of Nursing, we passed a comprehensive licensure bill that includes a very prescriptive scope of practice. At that time, it was a significant part of the discussion whether these VBAC services or vaginal birth after cesarean services would be provided by LDMs. And it's one of the main reasons that women seek these practitioners out and seek this model of care. And we did concede to prohibiting VBAC services at that time with the understanding that we would revisit the issue at a later time. And because of that, there was uncodified language that asked the Board of Nursing to look at this issue annually and also asked legislative services to look at other states where CBMs provide these services, which Delegate Cullison also mentioned, and other countries. And we're optimistic that under this balanced bill that increases access, but for a very low risk population, that we'll see the same success rates for VBAC services under LDEMs as we see for CNMs in the state. And the last thing I'll mention is in the last couple of years, we've done a lot to build trust and familiarity with this practice in Maryland. And that includes having support of the Board of Nursing on this bill and building relationships with other healthcare practitioners, other institutions, birth centers, and just a general familiarity with the bill. I'll close there, and I look forward to working with the committee on hopefully moving forward on this issue. And thank you very much.
Thank you very much. Let's hear next from Kira Brandon.
Good afternoon, Chair Pendergrass, Chair Kelly, and members of the committee. My name is Kira Brandon. I'm a practicing physician here in Maryland and also the president of Maryland Families for Safe Birth, which is the consumer organization interested in this bill. I'm testifying today in support of House Bill 1032. Maryland Families for Safe Birth often gets inquiries from women who are seeking a VBAC and struggling to find a qualified supportive provider. Even though VBAC is a safe and reasonable option for most women with a prior cesarean, more than half of the counties in Maryland have no hospital that will allow a VBAC. Even the hospitals who do support VBAC have rates around 15%, which is in contrast to the success rates for direct entry midwives, which are generally in the 80 to 90% range. I have personally experienced the lack of VBAC access in Maryland with the births of my children. My first birth was a cesarean section. And along with my husband, who is also a physician, we decided that we made an informed decision to have our subsequent children at home. My second child was born in Texas, where it's easy to find a direct entry midwife to attend a VBAC. And in Maryland, I was really frustrated and had a difficult time finding a direct entry midwife. First, it was because there were no licensed direct entry midwives. And then after licensure, it was because of this specific restriction. What this restriction means for me is that as a physician married to a physician, I'm not allowed to choose my maternity care provider or really the place that I give birth, because direct entry midwives attend most of the home births in Maryland. Direct entry midwives are willing and trained to care for women. Consumers are seeking this care. And this is part of addressing the access issue for VBAC in Maryland. Thank you for your time.
Thank you so much. It's nice to see you again. Let's hear next from Tova Brody.
Hi, good afternoon. My name is Tova Brody. I'm a licensed direct entry midwife in Baltimore, and I've been involved in the midwifery legislative efforts since way back in 2011. As Caitlin said, this is really a narrow expansion of our scope. It's just moving VBAC from that prohibited list to the requiring consultation list. And again, 23 other states who license LDEMs allow this. And honestly, the bill that we're proposing here is more restrictive than many of those regs. We are trained to provide care for these clients. We are competent. These clients are low risk, and there is a huge need for this. LDEMs get inquiries from VBAC clients all the time. We're constantly turning them away. There are a few certified nurse midwives who do attend home births and can legally attend these clients, and they're full. They are completely overbooked. As Kira said, there's counties in Maryland who don't have hospital VBAC access. The hospitals that do provide it don't have great success rates. I just wanted to share a birth story that actually inspired me to become a midwife. A dear friend of mine attempted a VBAC in the hospital with her second baby and ultimately was unsuccessful. And she feels that was largely in part due to the lack of evidence-based care with her facility and provider policy, the cascade of interventions that she ultimately faced, and just the lack of time that she needed to progress, which didn't happen. And with her third, she sought out a completely different model of care. Because of her physical and emotional trauma with her first birth, she sought out a midwife, and she had this beautiful, empowering, life-changing vaginal birth after cesarean at home. She felt completely respected. She felt safe. Her midwife was in the room monitoring her and her baby the entire duration of the labor and postpartum. And I was lucky and honored enough to attend that birth with her. And I walked out and enrolled in midwifery school to be that kind of provider, the provider who can provide evidence-based autonomous care. And I am asking for a favorable vote for HB 1032 so that I can provide services to these VBAC clients who maybe even more than the rest of the population deserves this kind of care. Thank you for your time, and I'm happy to answer any questions.
Thank you very much. Next up, we have Paige Baroka.
Hi, good afternoon, Chair Pendergrass and everyone who has came to offer their consideration for HB 1032. My name is Paige Baraka. I'm an RN and also an LDM in the state of Maryland, and I am here as the president of the Association of Independent Midwives in Maryland. We are an organization composed of both certified nurse midwives and licensed direct entry midwives who both fully support HB 1032 and the inclusion of vaginal births after cesarean within the scope of the LDM practice. We believe that licensed direct entry midwives are trained and competent to attend low risk birth, and that they are also capable of attending births that are these VBACs in this scope. We believe that VBAC in this bill will still remain to be low risk. Licensed direct entry midwives follow the same standard of care as their hospital counterparts, nurse midwifery counterparts as well, including routine lab work, genetic testing, ultrasounds, physical assessments, and their continuous risk screening allows for pregnancy, along with the collaboration of local hospitals, nurse midwives, maternal fetal medicine doctors, and other members of the healthcare team to remain low risk. LDEMs have established themselves as valuable care providers, offering unmatched continuous care throughout pregnancy and birth in the postpartum period. This continuity of care is just allowing them to give care that's no longer accessible given our model of care in the medical system. They're experts in physiological birth, another thing that is hard to find, and they provide care that's ideal for those seeking not just natural births, but births after trauma, which is all too common in the VBAC population. I very much urge you to consider being favorable in this bill, HB 1032, along with the rest of us midwives here in Maryland.
Thank you very much. We have questions. The first question is from Vice Chair Peña-Melnick.
Thank you so much, Chairman Kelly. I have a question. I don't know if the best person is Ms. Barrow or Ms. Brody, but can you describe to me the model of care for providing services to women who have had a C-section and how it differs from a regular model? And how do you monitor the risk? Can you just make it clear for us?
I'm happy to answer that, or Paige, you can jump in if I miss anything. Yeah, it's a great question. I would say it's honestly similar in line with how we risk screen our other clients. We are continually screening for any client who may kind of go into like a yellow flag zone to see if transfer is necessary. As midwives, we are experts in normal physiological birth, as Paige mentioned. And because of that, anything that kind of is slightly outside of that automatically goes on our radar. We are doing evidence-based intermittent fetal auscultation monitoring for baby. So we're listening to baby with a handheld Doppler at least every 30 minutes or more frequently as labor progresses. We are monitoring maternal vitals, which includes blood pressure, pulse, and temperature to screen for, again, hypertension, maternal infection, but also specifically for VBAC clients, we are monitoring their levels of pain, looking for any signs and symptoms of uterine rupture. Interestingly enough, at home, that's almost easier to screen for because you have an unmedicated client who is more in tune to what may be going on with their incision. In the hospital, when you have constant fetal monitoring, which is required, you have many clients who choose to use epidural anesthesia, and that client may not be as in tune or aware of a uterine rupture, which is, again, one of the risks that's often brought up with a VBAC client. So a lot of it is just monitoring vitals for baby and for mom, and again, really monitoring levels of pain, monitoring labor progression. And as Paige said, throughout pregnancy, just standard of care, ultrasounds, lab work, and routine prenatal testing to ensure that they are a good low-risk candidate before the labor even begins. And Paige can add anything I'd missed if she'd like.
We actually have one answer per question, but we do have another question from Delegate Kipke.
Thank you, Madam Chairman. I'd like to ask Caitlin McDonough, who's a very savvy lobbyist. I'm sure you have some ideas of what the opposition might say, and I wanted to give you an opportunity to respond to some of that and maybe also let us know what safeguards are in existing law and what safeguards would be here under this bill.
Sure, and thank you, Delegate. And I will also point out, I know there are provider representatives from the physician community and potentially from the hospital association that have voiced concerns, and I'll thank them both for talking to me preliminarily about the bill before it was introduced, so they were aware of the bill. And I do understand their concerns, and we hope to work with them to try and move forward on this issue. One thing I will note is, the risk is always going to be an issue with this. And I think the risk that we usually hear with a previous C-section, as Tova mentioned, is the risk of uterine rupture. And so what we tried to do with this bill, and we also looked carefully at other states, is reduce the population as much as possible to make it as low risk as possible. And that's why you see that incision that's less likely to rupture. That's why you see that there's been a long enough time since the C-section that it would have properly healed. And you would also see that it's only been the one previous C-section, not a repeat. So you don't have, an incision, again, that's more likely to rupture. We think that brings the risk level in line with what we see on the consult list that's in the existing legislation. And what I would add is not in this bill specifically, but would also apply to all of these patients under this expanded scope, or all the safeguards that are in our current very prescriptive scope of practice under our Licensure Act, which include very specific informed consent that is not only general but also specific to the patient related to this condition. We would be open to an additional level of informed consent around VBAC specifically, given its kind of new addition to the scope. There's also very strict parameters around transfer, around the plans that need to be filed ahead of time with the board as a general transfer plan, and then individualized transfer plans that include the consult with the other practitioner, the hospital or provider we would be transferring to, the transfer of information and medical records so that they have full information when they take over. All these things are currently in our law and would apply to these patients as well. So even if you're not seeing them reflected in the bill, they're there in current law, and that I think keeps us in line with other states, if not more restrictive. Thank you.
Thank you.
All right, next question is for Delegate Hill.
Thank you very much. Thank you, Allison. I guess this question would be for Ms. McDonough also. From what I'm hearing here, the criteria that you all are saying you would use to determine that a patient is a relatively low risk for VBAC are the same criteria that are being used in the hospitals now. There's nothing special in terms of doing it at home, and you are putting the transfer things criteria in there. But again, that's assuming that some percentage of the time something's going to go horribly wrong, just as it can in the hospital. So since my assumption is that no death is an acceptable death, what exactly, and even the consultation, I'm sure in 3 years, you'd come back and say, we don't need to consult with anyone else anymore because we've been doing this for 3 years. So the data from other places, what percentage of the VBACs being done at home end up being transferred to a hospital?
So I don't have the data in front of me for other states. I know this is something that Legislative Services has tracked and may have reported to the committee on, and I'm happy to work with them to get that information. I will note it's difficult to have the data for Maryland because we are dealing with such a small population. I think we could work with our counterparts in the certified nurse midwife population. I think there's 4 or 5 who do perform out of hospital VBAC services now on their transfer rates. I do know we have around an 80% success rate with people delivering vaginally with a nurse midwife out of the state. Currently in Maryland, out of hospital in Maryland is my understanding from the nurse midwives that we've worked with. I apologize, but and happy to get that data for you. But I mean, the idea, as you said, is to keep it as low risk as possible, so that even though if there is a small percentage, we're still able to grant access to this service without having to get into the higher risk areas. But I apologize.
Thank you.
All right, I don't see any more questions. I do have a question for Dr. Brandon. I just wanted to know if you had, since COVID started, has there been an increase in demand for out-of-hospital birth? Is this, how does COVID impact what you're hearing about in the community?
Yeah, absolutely. I mean, I think any medical provider would tell you across the board, there's been an increase in demand for out of office, out of hospital, out of institution medical services. Specifically for birth, we've seen a big increase. I hear kind of anecdotally, and I hear from all the midwives that they're seeing a huge increase in demand. I think there's a couple of reasons for that. I mean, the first is, of course, people are hesitant to go into a setting where they're going to come in contact with a lot of other people, and this sort of fear of COVID in the hospital. And the second part, I think, really is the changes in the policies in the hospital labor and delivery units that are less favorable towards someone achieving, the birth that they're looking for. And, I'm not commenting positive or negatively on that. That's just how it is because of COVID. A lot of hospitals are only allowing one support person, so you can't have a doula, and doulas have been shown to improve outcomes, reduce cesarean rates. They initially, although some have backed off from this, were testing everyone for COVID going in, and even asymptomatic mothers, their babies were being separated if they tested positive for COVID. So that impacts breastfeeding, bonding, all of that. And that goes against what the World Health Organization recommends, actually. I think that a lot of hospitals have gotten away from that now. But so I think there's those two pieces in play that are really driving this increased demand. And I think really, if anything, COVID has shown us that the risks and benefits of where you choose to give birth are not static. We can't say that, 5 years ago, the risks of hospital versus home for any particular population are the same as they are today. They're just not. Things change, and we're trying to adapt with that as well.
Thank you. I don't see any further questions for the panel of proponents, so we will move on to a panel of opponents. We have 4 people signed up. The first is Judith Gurdian.
Good afternoon. I am Judith Gerdian. I'm an OBGYN. I've been practicing for about 35 years in Maryland. In addition to being a practicing OB, I'm also past president of the medical staff and a past chair of the OB department at Shady Grove Hospital. I've practiced obstetrics long enough that I've seen the evolution in VBAC practices in the United States. With a good 40 years of experience doing them, that we've learned that VBACs are very safe if they're done in a controlled environment. In our hospitals, we have protocols that we follow that require physician availability and access to anesthesia and blood products on the chance that they may be needed. And this is whether we're delivering with a nurse midwife or a physician. Our patients all understand there's a 1% risk of rupturing the uterus, that it's a small risk but real, and that it does have dangers to mom and babies. In our hospital, midwives work with their supporting physicians who know a mom is laboring, and they're available instantly if they should be needed. Our high VBAC rate actually reflects our primary delivery rate for first-time moms. So we're running about 75 to 80% success rate for VBACs in our hospital. And when we have a successful VBAC, everybody in the unit is delighted and pleased. So then why not at home? If we just address the rupture issue, in a home scenario, the midwife suspects a rupture. You have to call an ambulance, wait for them to get there, transport the patient to the hospital, find the receiving physician, open up an OR, get the patient to the OR, and consent her. And unfortunately, most often in these scenarios, it may take time to convince the mom that she now has to change her expectations that she really had her heart set upon. The potential for a bad outcome in this case is significant. In addition, there are a number of data from new elegant studies that show there's a 10-fold increase in adverse fetal outcomes, including neonatal seizures, low APGARs, and a need for infant ventilators in babies who are born in the United States with home VBACs. Thank you for your time.
Thank you very much for your testimony. Jennifer Whitten.
Good afternoon, Madam Chair and committee members. Pleasure to be here with you today. Jennifer Whitten here representing the Maryland Hospital Association and our members in respectful opposition of House Bill 1032. Part of my testimony was going to remind the committee that we worked together, I think, in a really collaborative way in 2015 to pass House Bill 9 that really established, again, that pathway for licensure and scope of practice for direct entry midwives. And we were supportive of that with the agreement that there would be this exception as it relates to a previous cesarean births. And so we still feel very strongly about that. That legislation also required that an advisory council would be established that the Maryland Board of Nursing has been able to manage. And recently in their direct entry midwife advisory committee report that was issued in 2020, the board did not recommend expanding the scope of practice for licensed direct entry midwives, including previous cesarean births. And so I think our position is, we want to continue to collect data. As Delegate Hill had mentioned, we want to continue to work with the advisory council. And there's a number of representatives, probably some of the proponents today, and we also have a representative on that advisory council, but these are really the experts in their field that are helping us guide and make these decisions. So we would really respectfully ask for that advisory committee to give us those recommendations for this consideration. I was going to say that we have a physician here today, and just our focus really is the safety for mothers and babies. So we would ask that this committee give this bill an unfavorable report, but committed to the issue, committed to continue to work on this. So thank you.
Thank you very much for your testimony. Next up is Pam Casemeyer.
Hello, members of the committee. Pam Casemeyer here on behalf of the American College of Obstetricians and Gynecologists. Respectfully, also in opposition. I won't repeat a lot of what you said, and I am not a clinician. You have one more physician who's going to be speaking. But I think, as Ms. Whitten said, that the advisory committee that was that was created when you passed the legislation before, which we worked on as well, and think we have an excellent statutory and regulatory structure. They specifically considered whether to expand authority or recommend expansion of authority to VBACs, and the advisory committee just this fall recommended not to do so. And I think it's based on all the risk factors that that are associated with feedback. It may be a small percentage, but the outcomes and the issues related to a VBAC that does not go well are significant, not the least of which is the timing for transfer that was referenced in previous testimony. I also wanted to let you know that the National Institutes of Health, not professional trade associations, but the National Institutes of Health actually has a consensus statement that talks specifically about cesarean section or vaginal birth after cesarean section, and does not recommend that it not be performed, that it be performed anywhere but in a facility that has surgical nurses, operating rooms, the ability to deal with the unexpected but very possible rupture or other issue that cannot be well managed if it is not in a facility setting. So that comes from the National Institutes of Health, which in many ways is much more independent than you may even feel. Some may feel that professional organizations are. With that, we'd respectfully request an unfavorable report.
Thank you very much. The final panelist, I'm going to assume is Dr. Jennifer Villavicencio.
Yes, good afternoon, and thank you for having me. I'm Dr. Jen Villavicencio, and I'm a board certified practicing obstetrician gynecologist. I'm here representing the Maryland section of the American College of Obstetricians and Gynecologists, or ACOG. I come to speak about HB 1032 because ACOG cares deeply about the health and well-being of the mothers that we take care of. This legislation concerns, as you've heard, the ability of direct entry midwives to provide care for pregnant individuals who have previously had a cesarean section. I deeply believe that pregnancy and childbirth care matter to ultimately be decided upon by the pregnant person. And although I am a physician, my training in obstetrics, labor and delivery is primarily from the incredible midwives at Brown University, and midwifery is a profession I have profound respect and admiration for. I continue to work collaboratively with midwives in the practice of obstetrics. It's with this deep respect for patient autonomy as well as the profession of midwifery that I come to you today to discuss the complexities of the practice of obstetrics and ACOG's respectful opposition to this bill. We're in the midst of the worst maternal mortality crisis in decades in this country. Pregnant people and new mothers are dying preventable deaths on a daily basis. Black women and other people of color face even more dire risk in each and every pregnancy. The urgency to find solutions for this crisis is palpable, as is the importance of addressing our community's concerns. Trial of labor after cesarean, or TOLAC, is generally, as you've heard, a very safe endeavor, given that the risk of uterine rupture is low. However, the consequences of uterine rupture can be absolutely catastrophic, leading to life-threatening maternal hemorrhage, oxygen starvation for the fetus, and possibly death for both. I unfortunately have treated several uterine ruptures and their devastating consequences, and know that had we not been within literal minutes of being able to operate, my patients would have died. I also keenly remember how subtle the signs of the rupture were at first, and had I not had nearly 10 years of experience combined with the decades of experience of my team members, we may have missed the diagnosis and intervened too late. Relied on continuous fetal monitoring and immediate signs of fetal distress, as well as the continuous vital sign measurements to identify the devastating rupture. I can stop here or have a little bit more.
Why don't we have you conclude your testimony, and we'll see if we have any questions, but you got like 2 more sentences to wrap it up. It's good.
Yep, that's it. It's incredibly important to me that women be able to make the decisions about how and with whom they birth their children. Safety, that we ensure the safety of these.
Attempt to present the bill briefly. So thank you for having me, members of the committee. This is House Bill 1039, State Board of Massage Therapy Examiners revisions. This is a pretty simple bill. It modernizes, does a couple of things. It modernizes the criminal background check process. We've seen this with across health occupations over the last few years. It standardizes higher education accreditation statewide. And it gives the board authority to create an inactive status, which will make it easier for massage therapists to return to practice after time away from the profession. So there's two major changes to the statute in this bill. Again, I mentioned the standardizing the accreditation for massage therapists. The Commission on Massage Therapy Accreditation is the nationally recognized as the organization that's qualified to create the specialized national standard for massage therapy education programs. So it would require CompTIA endorsed curriculum at all massage schools in Maryland to bring a higher level and more consistent standards to the massage therapy training programs. Secondly, it modernizes the criminal background check process. Again, we've mentioned this, in multiple bills over the last few years. I do want to note that about half of massage therapists in practice in Maryland would be required to get new fingerprints to comply with the law. However, the association has advised us that the burden of time and expense is reasonable in relation to the benefits of the new system for the state board and their responsibility to protect the public. So they are supportive. The bill also makes some technical changes in the statute, including a variety of language updates to modernize the language. There's some old French terms in there. We'll hear more about this from the panel, so I won't take up too much time, but I do want to note that there is a letter in your file from the Bodywork organization asking for an amendment. We have that amendment in drafting. It's really quite a technical amendment, but we are absolutely fine with moving forward with the amendment that is requested. With that, I'm going to move on to the panel. Let's hear first from Amelia Mitchell, and you can take my extra 3 minutes if you feel like you need it, Amelia.
Wonderful. Thank you so much, Delegate Kelly and the whole committee. My name is Amelia Mitchell. I am a licensed massage therapist and a board member with the American Massage Therapy Association, Maryland chapter. Here today to ask for a favorable report on HB 1039. And as you said, we are in favor of this very technical but important amendment that is being drafted at the moment. We've worked closely with the Maryland Massage Board in the creation of this bill to update our Practice Act, get to 2021. The board has licensed or registered massage therapists for over 20 years with over 4,000 professionals currently under their authority. During that time, language, technology, information access, it's all shifted. So first, as you've heard so many times from at least 10 or 12 other boards, we want to get that modernization in for the criminal background check. So the board actually can get information about what's happening if somebody has committed a crime, and they would get that information far sooner than the required update at every 2 years during renewal. The CompTIA accreditation is also important, bringing a higher standard to massage education from the Commission on Massage Therapy Accreditation. This means future students will be assured that their education has properly prepared them to pass their licensing exams and enter their new career. It also assures the Maryland Massage Board that those applying for licensure have fully been trained in massage therapy, and this protects the public, obviously. The bill also creates an inactive status that simply allows people to return to the profession if they've left without as many hurdles, so to speak. And honestly, right now, that's a really important thing for many therapists. Inadvertently, here's the amendment. One of the changes in the bill as written removed a part of the definition of massage therapy. And that allowed for energy practitioners to work without licensure. The amendment will return that language to the statute. And what it means is that those who solely practice energy techniques that only affect the electromagnetic field of the body and only work on fully clothed clients can continue to practice without the need for massage licensure. This is a narrow exclusion that has been in place for 20 years. And honestly, the majority of these practitioners are actually licensed or registered massage therapists already. Some other intended changes clarify some of the definitions and remove outdated terms because, as Delegate Kelly said, we don't need to speak French to talk about massage. It also eliminates some unnecessary language regarding insurance coverage. For communicable disease precautions, something we're all too familiar right now, it updates us to the current and correct CDC guidelines known as standard precautions, all to get us to the 21st century. So I thank you for your time and attention to this legislation. The American Massage Therapy Association Maryland chapter appreciates a favorable report of HB 1039 with this pending amendment. And of course, I can answer questions. Thank you.
Thank you very much. Let's hear next from Paula Jelanis.
Sorry. Good afternoon, Madam Chair, Delegate Kelly, and committee members. Thank you for the opportunity to speak. My name is Paula Jelanis. I am a licensed massage therapist. I am also the vice chair of the Board of Massage Therapy Examiners, and I'm here to testify today on behalf of the board in support of HB 1039 submitted with the amendment by the American Massage Therapy Association. We are in agreement with and support the changes to the definition of massage therapy and to the updates of the other language that cleans up the statute and makes it more readable and understandable for the layperson. A COMTA-endorsed curriculum will better protect the public by raising the educational standards, ensuring more uniformity in school curricula across the state, and increasing the pass rates for the licensing exam, thereby reducing financial burden for the students. The wrap back offers protection of the public by immediately notifying the board of criminal activity such as sexual assault. This will enable the board to promptly initiate an investigation rather than leaving it to the receipt of a complaint or waiting till individuals may self-report during the biennial renewal cycle. The language changes for the insurance reimbursements brings the profession of massage therapy in greater alignment with other healthcare professions. Thank you for the opportunity to speak, and we are hoping for a positive outcome for HB 1039, and I'd be happy to answer any questions. Thank you.
Thank you very much. Do we have questions from this committee on this for this panel? I'm going to give you guys a second to raise your hands. Just to make sure. I see no questions. So you guys did a great job explaining. Oh, wait, I see a question. Delegate Bandari.
Yeah, thank you, Madam Chair. This question is to Amelia. I am wondering why this energy technique was excluded from massage therapy. Reiki, healing touch, that polarity therapy, they are the part of the massage therapy. Why do you think they were excluded from the definition?
Well, I was not actually in the process in that. I have only been licensed for 15, 16 years now. However, my understanding and truly my experience with these modalities, I'm trained in Reiki, I'm trained in reflexology and a couple of others. These are things where there's very little risk of harm to the client. And these are modalities that a lot of people who would not be really doing massage can access for healing and energetic health, shall we say. So they've been excluded from the beginning because what's required of individuals practicing these things is not the same level of training that would be required for somebody with massage therapy. It's important, though, that things that are in there, there are very specific language about pressure or movement, and there's very specific language about the clients must be clothed at all times. So it's pretty narrow. And honestly, a lot of the people that get started in one of those areas often discover they really want to do more as massage, and they end up going to massage school so they can truly practice everything.
Thank you.
So seeing no further questions and having put my file out of reach, let me grab it and see who's next on the list. Tom Swift, I believe, Swiss.
Yes, Swiss, like Swiss Army knife.
Yep.
Thank you, members of the committee. My name is Tom Swiss. I am a Maryland licensed massage therapist and a nationally certified Asian bodywork therapist. I am concerned about the proposed changes to the statutory definition of massage therapy, removing the exemption for Asian bodywork therapy, or ABT, and other forms of energy work. I am glad that an amendment is being discussed, but it's important that the committee understands the underlying issues. It's unfortunate that the authors of this bill did not reach out to groups affected by this change. We learned about it by chance at the last minute. There's an important rule of equitable legislation: nothing about us without us. I alerted the AOBTA, our professional organization, and they have provided a statement which is included in my written testimony. Asian bodywork therapy is a profession and an art which borders on massage therapy on one side and acupuncture on another. We view massage therapists and acupuncturists as colleagues with some overlap. In fact, I will be teaching an ABT class at the Potomac Massage Therapy Institute later this month. But just as a first aid class doesn't make a student an emergency medical technician, so one day of acupressure training doesn't make a massage therapist an ABT. Our arts, professions, and training are distinct. Like acupuncture, ABT is rooted in the Chinese medical theory of qi and the meridian system. It is rooted in East Asian philosophy. We ask you to honor the distinct theoretical roots and cultural notions of wellness involved. The existing definition of massage therapy includes language which exempts the ABT profession, as well as practices like reflexology, Reiki, Qigong, and other forms of energy work usually practiced in a less professional context. These practices do not threaten the public. The redefinition would invite the board to put onerous and costly regulations on practitioners, but the board does not have the necessary knowledge of these arts to regulate them. State regulation is unneeded, but if they were to be regulated, this should be done separately by a body with the appropriate expertise. I urge you to oppose this bill unless it is amended to preserve the current statutory definition of massage therapy. Thank you for your consideration. I'll be happy to take any questions here, or my email is included in my written testimony. Thank you.
Okay. Let me look. I see no hands raised, but I'll give you a second to think about that. Okay, seeing no hands raised, that is the last witness on House Bill 1039. And we'll now move to House Bill 1193. Delegate Adams, are you here? Oh, there you are. You're muted, Delegate Adams. You need to unmute yourself.
Thank you. Thank you, Madam Chair and committee members. I'm here to present House Bill 1193, Certified Nursing Assistants, Certificate Renewal Training Program Requirements. This bill is a cross-file with Senator Eckhart. The bill is being introduced to meet the healthcare demand and replenish our healthcare workforces. HB 1193 will allow the Board of Nursing to create approved refresher courses for those nursing assistants who have been certified in the past, but who may have let their certificate expire for over 2 years. We believe that it's an important pass now. During the COVID-19 pandemic, the struggle to meet the healthcare demand and replenish our exhausted workforce has become a significant issue. The refresher courses will expedite the process of returning our certified nursing assistants and geriatric nursing assistants to the healthcare workforce. I would ask the committee to view this bill as favorable, and we do have a sponsor panel and would ask that we take that testimony at this time. Thank you very much.
Thank you, Delegate Adams. We can hear from Karen Evans.
Thank you very much. And thank you, Chairman and members of this committee, for allowing the board to speak, provide their testimony today. We are in complete support of House Bill 1193. There has been a great need for creating CNA refresher courses in the state of Maryland. The board has worked with the community over the last 3.5 years and have received outstanding support from stakeholders, CNA training programs, as well as legislators in spearheading the efforts to adopt the refresher courses for both CNAs and GNAs. Many benefits can be gained from instituting refresher courses, particularly the individuals who are returning back to the workforce. Refresher programs will allow the pool of CNAs and GNAs who have been expired, non-renewed, or on extended medical leave to enter the workforce in a shorter period of time. Currently, CNA and GNA programs are approximately 6 to 8 weeks to complete them, and can also cause a financial burden on the students. So with the introduction of the refresher programs, the time of instruction will be limited to a week. The shortage of direct care workers has been abundantly clear, not only during COVID, but prior to that. The board believes that the refresher programs will reduce the barriers to re-entry into the workforce and will help in mobilizing direct care workers. Lastly, the state of Maryland will be in line with our bordering states, Virginia and West Virginia. Both of them have refresher programs. For this reasons, the Board of Nursing respectfully asks the committee members to give a favorable response, and thank you for allowing the Board of Nursing to testify. And thank you, Delegate Adams, appreciate it.
Thank you so much for your testimony. Do we have questions from the committee for this panel? Give you guys a second to raise your hands, but I am not seeing any hands up, which means you did a great job of explaining the bill. So I think that will conclude the hearing on House Bill 1193. Thank you so much.
Thank you.
We will move on now to House Bill 634, Delegate Beitzel, which is Association Health Coverage Plans. Delegate Beitzel, are you here? Melissa, do we know if he's here or coming?
Yeah, he's joining. Just give it
Perfect.
1 second.
After this one, we have 2 more brief hearings, and then we should be wrapped up.
Okay, who's that? Are you waiting on me?
Yes, we are. We're so happy to see you. We just called House Bill 634, so go ahead and start your bill introduction.
All right, thank you very much. For the record, this is, whoops. I got, they threw a time thing up there on me. Okay, for the record, this is Delegate Wendell Beitzel. I'm here to present House Bill 634, Association Health Coverage Plan. This bill is really to create a group health insurance association plan that allows associations to have small group plans, like an umbrella policy under the associations. And the association that requested this is the Chamber of Commerce in Garrett County, but there's other associations that are going to be on here to testify also in favor of this bill. And it would also, the Farm Bureau has expressed an interest in other associations. So I want to thank Delegate Collison for working with us, trying to come to some agreements or something where that would be possible for this bill to move forward. There's some concern from the Maryland Health Insurance Exchange, thinking that perhaps this would impact their small group policies. And also Delegate Collison, there was some concern in the bill. We've worked on some amendments, and we've offered some amendments on this bill to address those concerns. So with that, the person that really is the person that is requesting this bill and has extensive knowledge on the plan and can explain the plan that we're trying to get for the Garrett County Chamber of Commerce, it is Nicole. Is she on? Nicole Christian from the Garrett County Chamber of Commerce. Can I turn it over to her?
Absolutely. Nicole, are you here?
I am here.
Excellent. We will add the delegates 3 minutes to your 2 minutes, so you can take up to 5 if you need.
Well, thank you. Hopefully I won't need that much. Good afternoon, Madam Chair and committee members. Thank you for the opportunity to be here today. I'm Nicole Christian, President and CEO of the Garrett County Chamber of Commerce. I'm here on behalf of our 600 members in support of HB 634. And I want to thank Delegate Beitzel for sponsoring this bill for us yet again this year. We do support HB 634, and additionally, we support the amendments that have been filed, which will ensure oversight of these plans by the Maryland Insurance Commissioner, and it allows the plans, it allows the small employers in these plans to be grouped together for the purpose of rating them as a large group. You have heard 2 other bills today already that discuss the growing number of uninsured and that it can be too costly for small businesses to provide health insurance for their employees. The premise of this bill is very simple. By allowing the creation of association health plans in Maryland, you could be potentially saving our small businesses thousands of dollars and provide health insurance to thousands of uninsured Marylanders. It allows small businesses to pool or group their employees together through an association and then be rated as a large group, the same as a large business with hundreds of employees. These businesses would then have access to rich health insurance plans at affordable rates because they're spreading the risk across many lives instead of just the few of one small business. These are not mandate light or dumbed down plans. The plans must include all the benefits mandated by the ACA and by the state of Maryland. AHPs are not allowed to cherry pick or discriminate based on prior health conditions. We want to work with Maryland insurance companies, and we are not trying to skirt Maryland laws or attempting to purchase insurance from out-of-state providers. These are quality plans at affordable rates provided by insurance carriers. They're not self-funded plans or MEWAs. And additionally, there is absolutely no evidence that the creation of association health plans will negatively impact the small group market in the exchange. Because AHPs are prevented from cherry picking and denying coverage, they'll have a mix of sick and healthy businesses participating. It does not mean that only sick businesses will be left to participate in the small group market. 12 states have already adopted rules to support AHPs and have seen little to no effect on the small group market. So basically, you're letting small businesses pull all their employees and have access to better plans at better rates because they're spreading the risk across those lives. At a time when access to affordable healthcare has never been more important, allowing the creation of association health plans would provide thousands of Marylanders with health insurance at no cost to the state. In fact, the fiscal note reports that it would actually generate revenue for the state. With all of that information, and I'm happy to answer any questions, we respectfully request House Bill 634 with the amendments provided receive a favorable report. Thank you so much.
Thank you very much for your testimony. Next up, we have Andy Stern. Is Mr. Stern here?
I'm sorry, I forgot to unmute. Rookie mistake.
Oh, it happens to the best of us, Andy. Go ahead whenever you're ready.
Good afternoon, everyone, and members of the committee. My name is Andy Stern, president of Andy Stern's Office Furniture, testifying today on behalf of the Greater Bethesda Chamber of Commerce, Delegate Kelly's hometown Chamber of Commerce. Today, I am here to support HB 634, Association Healthcare Plans. This bill would allow chambers of commerce and labor unions, as you know, to create eligible association health plans as defined by the U.S. Department of Labor. My testimony today is twofold. First is the immediate past chair of the Greater Chamber of Commerce of Bethesda and our more than 500 member businesses and their 45,000 employees. And second, the president of a small employer doing business in Montgomery County and the state of Maryland. We believe that by enabling chambers and unions to provide their members the option for participating in association health plans, more businesses will be able to thrive and grow, knowing that their employees are provided good, affordable care, which is one of the hardest things you have to do as a small business owner, believe me. We're not looking for simplified or mandate light health insurance through AHPs, but rather we would like to provide the employees of our members comprehensive health insurance plans that have competitive rates. We believe the best way to do this is through AHP. Wearing my hat as president of a small business in Montgomery County over the past decade, we have experienced firsthand the increasing costs of doing business in Maryland. We know that some of you own your own businesses and understand the problems we face, especially in trying to keep and help our employees deal with the increased cost of health care, especially those who are over 40 years old. Passage of this bill will not only help small employers that are struggling to stay in business, but also will send the message to those companies considering opening a new business or expanding here in the state of Maryland, that Maryland is business friendly and understanding of the issues small businesses face. For these reasons, we request a favorable report on HB 624. Thank you all.
Excellent timing, Andy. Next up, we have Sarah Price.
Thank you. Good afternoon, Madam Chair and honorable members of the committee. My name is Sarah Price, and I'm here on behalf of the Maryland Retailers Association. First, I'd like to thank Delegate Beitzel for sponsoring this legislation yet again. As the Retailers Association represents businesses of all sizes all across the state. And the number one question that we hear over and over again every single year from our small and independent members is, can you help us with healthcare costs? And unfortunately, every year we have to say, no, we can't. As you've heard all afternoon, independent businesses, small businesses, they want to be able to offer healthcare options to their employees, but it is often cost prohibitive to do so. This bill would make it so that businesses can offer the healthcare benefits to their employees that they desperately need and make healthcare more accessible to everyone in the state. We would urge a favorable report in short. Thank you.
Thank you very much. Delegate Beitzel, we have two people signed up favorable with amendments, but I think they may be part of your panel as well. Is that the Allegheny County Chamber of Commerce and the Maryland Farm Bureau? Are they with your panel, or should we go to questions now?
I think you can go ahead and go to questions.
Okay, great. So let's get questions from the committee. Do we have any questions from members of the committee? I guess, Delegate Lewis.
Thank you, Madam Chair. Thank you, Delegate Beitzel, for bringing this bill. I really appreciate your commitment to helping expand access to healthcare insurance. It's so important. I guess I'm curious, because I don't understand association plans as well as other plans. What do association plans offer that we don't already have in our existing statewide SHOP program? That's the state health program, small business health program under the ACA. Whoever's best to answer.
Yeah, I'm going to take a first crack at this, but I'm going to ask Nicole if she would, because she's the one that's really worked hard on this and trying to put it together. But so
Delegate, I appreciate your answer, but we have one answer per question. So if you think Nicole can give a better answer, we can just pop it over to her.
All right, we'll just pop it over to her then.
Okay, Nicole.
Thank you, Delegate Beitzel. Delegate Lewis, to answer your question, there are good plans that are available through the current exchange. However, the costs are still prohibiting our small businesses from being able to purchase those plans. If you look at the plans that large companies are able to provide, if they have 300, 400, 500 employees, they can get much better premiums, much better rates. And so therefore, because you're spreading the risk over so many more lives, if a small group is just based on the employees in their group, then their costs tend to be higher for the really high quality really rich plans. We've been talking extensively with the health exchange to see if there is a way to work together, but you have to limit the number. They do not provide large group plans, only small group plans, and they're limited on the number of employees that are considered a small group. It cannot go above 99, where an association health plan could pool so many small businesses where we would have so many more employees in that pool and therefore have better premiums, better ratings and better prices on the premiums.
And if may I have a quick follow-up, Madam Chair?
Yeah.
Are you saying, and thank you for that answer, Ms. Christian. So are you saying that association plans that offer plans for 100 members and above, that those plans could have better premiums than the existing marketplace plans? Why not just have employees join the marketplace? Some folks might be eligible for Medicaid. I was just trying to think about, you know how hard it is to start an insurance plan and how we could help small businesses and the employees of small businesses by tweaking what we've got.
So again, we have been discussing this with the exchange to try to figure out if there's a way to do it. We promote the exchange and the small group market all the time. It is my understanding, by talking with my counterparts in other states who are offering these plans, who also have exchanges, because you have so many more lives insured, you can get better rates for those plans. The same again as you have with a large employer. The small group or the exchange does not provide plans for large group or large employers. So all the research that we've done shows that the premiums would be significantly lower through an association health plan for these small businesses that have 5-10 employees.
Great, thank you. Thank you, Madam Chair.
Absolutely. Delegate Bagnall.
Thank you, Madam Chair, and thank you to the bill sponsor. I know this was a concern for the Farm Bureau last year. There are two things I'm not seeing in the bill, and maybe the amendments address them. But not every business is a small business that's part of a chamber. So is there a limitation on the size of the business that's part of that association? And there's a concern about oversight of these policies, and I don't know if that is addressed in the amendments, because I didn't see where that would be addressed in the bill.
Maybe Nicole, you can handle that one also, please.
Yes, definitely, Delegate Beitzel. Yes, the amendments do address both of these issues. Well, specifically addresses the oversight issue. So the plans would, the Maryland Insurance Administration would have oversight. It also addresses rating these groups as a large group. There is, based on the Affordable Care Act and through our exchange, the group size, once you go above 99 employees, you are then a large group. So it's a small group. Anybody that's going to be in the small group market through the exchange has to have 99 employees or less. So what we're talking about is helping these small businesses pull together so they can be a large group. But yes, currently, you're right, not every small business is a member of a chamber or an association. So not every business is going to participate in these association plans. But what we're hearing from the Congressional Budget Office is they estimate that over 300% growth in insured individuals because of these association health plans.
Thank you. Thank you, Madam Chair.
Absolutely. Delegate Bhandari.
Yeah, thank you, Madam Chair. It's wonderful bill, but when I was reading the fiscal notes, it says the bill excludes a multiple employer trust or association in this state or another state from the definition of health benefits plan. That's one concern. And another one is you have been trying to persuade the committee that a premium will be way low. Is there any evidence, research evidence about the quality that you could send to us?
Yes, actually there is. I can share with you the information that I have that shows premiums would be about 15 to 20% lower, which can mean the difference between a small employer being able to provide health insurance or not. And back to your question regarding the fiscal note, again, the amendment addresses the situation that the Maryland Insurance Administration will have oversight of these plans. So that where that was included in the fiscal note, that has been addressed.
Madam Chair, if I can, why the bill excludes a multiple employer trust or association in this state and or in another state? What will be eventually, what will be that effect? I mean, how that will affect?
So if it was an out-of-state plan, then the Maryland Insurance Administration would not have oversight. That, at least that's what we have understood through our conversations with them, is if you have an out-of-state plan, then there would not be oversight.
But our amendment addresses that, right?
Okay,
Yes.
I will talk offline because of the lack of time.
Delegate Bhandari.
Thank you.
Okay, I see no further questions for this panel, but we will move on to a panel of favorable with amendments. Julie McCoy.
Thank you so much, Madam Chair, and thank you. I'm coming to you having traveled across our beautiful state today, so I'm in my car. I apologize. My name is Julie McCoy. I'm the Executive Director of the Allegheny County Chamber of Commerce, just east of Garrett County. And we're in support of House Bill 634 with the amendments that have been highlighted in this discussion. I'd like to share a little bit of information with you regarding working households in Allegheny County and how that relates to the importance of association health coverage plans for our chamber members. In the most recent ALICE report that is published by the Statewide Association of United Ways, asset limited income constrained employed residents of Allegheny County make up approximately 30% of our population. These are working households who earn above the federal poverty line, and they are not earning enough to afford basic necessities, including healthcare. The number of households steadily has increased between 2016 and 2018, and is undoubtedly increasing further due to pandemic-related employment reductions. In Allegheny County, the ALICE report indicates that a household of 4, that's 2 adults and 2 children, must have an annual income of over $64,000 in order to meet all basic needs, which is actually $20,000 more than our median household income. 27% of our labor force is employed full-time and paid hourly. These employees can be categorized as restaurants, accommodations, recreation, and even healthcare, and many are employed by small businesses that currently can't provide healthcare. This creates difficult choices that households ultimately have to make, and typically healthcare is one of those basic necessities that falls off of their budget. By allowing chambers of commerce to provide this added benefit to its membership, pulling those employees together with others, we create an opportunity for more affordable and accessible healthcare to those who otherwise would be without. With that, I hope you will give House Bill 634 a favorable report, and I thank you for your consideration and your time.
Thank you very much. Next is Colby Ferguson.
Thank you, Madam Chair, members of the committee. Colby Ferguson on behalf of Maryland Farm Bureau, and we come in support of this bill as well, and support the highly support the amendments that were offered by the sponsors. We believe it cleans up and clarifies some of the major concerns and the things that will just make the plans better and more efficient for the members. We come in support with an amendment as well to add Maryland Farm Bureau, and the reason for that is that the members that we represent are the farmers in Maryland, and the vast majority of our membership are sole proprietor members, meaning that they are family farms and they are providing their own insurance through the Maryland Health Exchange as an individual family. And if you've ever looked into that component of the Maryland Health Exchange, they only give one option to pick from. So it's basically take it or leave it. And what we would be providing if we were to get this option is to give that opportunity for another option out there to try to help. We've talked to several of our farmers and asked them what the price would be or what they're paying, and it's in upwards of $19,000 a year just for health insurance to try to provide for their family. And so by adding Maryland Farm Bureau in, we're members of the chamber, the Maryland Farm Bureau is, but when you look at our membership, they're not going to be the same businesses that the chamber would be advocating for. And we believe that by redirecting those sole proprietor members into an exchange that would be really focused for them, I think it would be more advantageous and help both plans. So we hope and encourage that you will move this bill forward this year. We think this is desperately needed. Health coverage is easily one of the top reasons for farmers to get out or not get into farming. And we hope that you will move this so we can try to help relieve those pressures. Thank you.
Thank you very much. Do we have questions for this panel from the committee? I'll give you guys a second to raise your hands just in case there's any questions. I am not seeing any hands up. So with that, that concludes the hearing on House Bill 634. Thank you all so much. We have two more bills to do. The first one is House Bill 1063, Delegate Resnick. My eyes are bad. Insurance, Medicare Supplement Policy Plans, Open Enrollment Period Following Birthday. Is Delegate Resnick here? I do see him logging in, so we will wait for him to present his bill in just a moment. And we have two witnesses on this bill and one witness on the following bill. Delegate Resnick, are you ready?
I am, thank you.
Excellent.
Sorry, I was having some voice issues here, but thank you all for having me. I appreciate it. Are we ready to begin?
Yes, please do.
Thank you. I am here to present House Bill 1063. It is a bill that you all have seen two other times before, so I'm going to be very brief in terms of my explanation of it. I think you all remember it. This is the bill that we refer to as the birthday rule. It applies to Medicare supplemental plans. And essentially what the bill would do is it would allow seniors who are on a Medicare supplemental plan to be able to switch plans within the 30 days, following the 30 days of their birthday. The reason why that's important is that at the moment, they're not allowed to do that. They have the freedom to subscribe to whichever supplemental plan they want to when they turn 65 and get on Medicare. But once that happens, they are locked in and cannot switch plans without medical underwriting, meaning that they can't just simply switch plans unless their health is assessed and their risk is assessed by the insurance companies. And there's no guarantee that they will get a lower premium or a better coverage after that. What this bill will do is it allows them within that 30-day period to be able to switch to any other plan, to a cheaper plan, to a plan that might have more benefits, to be able to let them get access to the care that they need. This has worked very well in two other states, California and Oregon. There are plans in effect similar to this that are much more expansive in places like Oregon, Vermont, where they can do it at any time of the year. And last year, we heard this bill and you all asked for us to go to the Insurance Administration to do an actual study because the opponents of this bill, the insurance carriers that carry supplemental policies, insisted that this will cause detrimental effect. We now have a study from MIA. And I believe all of you have been granted access to that study. If you don't, we have submitted it, but if you don't, I'm more than happy to email it to you. And what I want to do, just to end this, is to read to you the top line finding of that study. And what it says is, from the MIA's perspective, the data reviewed suggests that the adoption of a birthday rule in Maryland would not likely have a negative impact on competition and choice if measured in terms of the number of legal entities willing to write Medigap coverage in Maryland, and would have a favorable impact on choice if measured in terms of the options available to individual enrollees. The data reviewed also suggests that the MIA to the MIA that the birthday rule is unlikely to introduce anti-selection features at a pool level and will result in higher overall premiums in the Maryland market. Rather, it appears that the birthday rule would likely act to counter the renewal anti-selection that currently exists, because the sickest individuals cannot move to other plans, but the healthy ones can. Over the short and long terms, opponents of the bill contend that the impact of the pool rates would be double digits, while those who favor the bill assert that the impact is more likely to be plus or minus 2% range. The OCA within the MIA believes that the latter figure is better supported by this data. In short, what this bill will do is it will lower premiums for seniors. It will not create an anti-competitive situation, and it will provide seniors the opportunity to be able to switch in what is essentially an open enrollment period around their birthday. The same kind of open enrollment period that you and I get to enjoy on our employer-based or exchange-based healthcare. Seniors have a right to be able to access this kind of policy. They have a right to be able to be treated the same way that the rest of us do. And the reality is, seniors do not get healthier as time goes on. That's just the truth. And it's also the time in their lives when they are least likely to be able to afford higher premiums. We have to allow them this access. And through our own MIA, they have determined that it's not going to have an adverse effect on our market. So with that, I want to thank you for your time, and I ask for a favorable report on this bill. Thank you.
Thank you, Delegate Resnick. Let's hear from Harancham Gochian.
Thank you to my delegate, Chair Kelly, as well as committee members, and especially to Delegate Resnick for introducing this common sense legislation. My name is Harancham Gochian. I serve as the CEO for Dialysis Patient Citizens. We represent about 28,000 kidney disease patients nationwide. And in fact, they're one of the more vulnerable patient populations. And so obviously, while this legislation looks at providing access, especially for seniors, I think it's important to note that about 15,000 dialysis patients live in Maryland, and about half of those are under 65. One of the reasons why this legislation was also brought up in the past was because those on disability also access Medigap plans. And when I was asked to testify on this legislation last week, I was actually shocked by the pushback from insurers. One, because the Affordable Care Act, for example, was supposed to end discrimination based on health conditions. And in Maryland, it's important to note that insurers in Medigap plans are allowed to charge sicker patients on disability, or on dialysis under 65 more, first and foremost. And second, those insurers are only required to offer, one plan option, Medigap Plan A. And so to me, for our membership, this is a really common sense, straightforward approach, so that if they're being asked to pay as much as 50% more than a 65-year-old patient, and they need to get this life-saving either dialysis or transplant, that they can then look at which plans are most affordable. The Senate committee chair asked for insurers to recommend some compromises. And, I don't know if they are today, but, one potential would be to make it community rated to end that discrimination. Another one would be to provide access to all the Medigap supplemental plans that are available, and potentially add a special enrollment period. But at the same time, what makes the most sense is a common sense approach, which the delegate is taking here, with an annual enrollment option for all seniors and for all individuals. So thank you, delegate, for introducing this legislation.
Thank you. Do we have questions from the committee? I'll give you all a second to raise your hands. I'm gonna just make sure there are no questions. Wonderful. Let's move on and hear from the opposition panel, which is Kimberly Robinson.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Kimberly Robinson. I'm here today on behalf of Cigna with respectful opposition to House Bill 1063. As Delegate Resnick said, we've been here for the last couple of years discussing this bill and have had some very robust conversations in the Health Insurance Subcommittee. And at the end of the day, our position has always been, like all things before the General Assembly, this is a policy decision that you all have to make, and there's always two sides for every policy that you may choose to implement. We have no quarrels with the conclusions that the Maryland Insurance Administration found in their letter, but I think there's a lot more to be understood than just the top line conclusion. And if you read thoroughly through the review, which we agree with the conclusions, I'm going to highlight a couple of things that really align with why this bill has raised concerns for my actuaries. This is not a bill that's about my sales team. It's my actuaries who actually have dealt with the rates and dealt with this proposal in the other states. In particular, Oregon is the most recent state and one of only 2 others who've adopted a bill similar to this one. And in the MIA's letter, they do surmise that the market impact would only be a 2% net increase in the Medicare supplement market, but they do acknowledge a 2% market-wide increase. But if you read the details in their letter, a close read of the MIA's letter finds that the MIA recognizes the reality that, quote, the birthday rule is likely to drive up the lowest/standard rates. That appears on page 7 of their letter. And they go on to talk about experience in Oregon and state that they believe, quote, the MIA believes that this description of the impact of the birthday rule in Oregon is an indication of what is most likely to happen in Maryland. We now see a lot of members' adverse selection on the lowest cost insurer on the market. After the insurer becomes the lowest rate on the market, or in the lowest quarter of rates maybe, the insurer sees sharp losses and can justify rate increases between 15 and 30% the following year. We also see another year or 2 of higher than normal rate increases after the first sharp rate increase as members level off and leave to other insurers. It's this volatility and the specific experience of individuals in that market who do find themselves seeing very sharp increases that do not happen in states like Maryland today. That's always been why we have concern. I look forward to the conversation in the subcommittee, but respectfully oppose House Bill 1063.
Thank you, Ms. Robinson. Do we have any questions for Ms. Robinson? Let's give it a second, just in case someone's reaching for their computer. All right, that's it. No questions. That concludes the hearing on House Bill 1063. Thank you all so much. Oh, wait, just kidding. Not concluding. Delegate Krebs reached her computer. Delegate Krebs.
And I'm not going to ask you a question. I'm just going to thank Kim for putting her testimony in writing so that we could read it. And I really appreciate it when the carriers do that. And I just want to thank you. That way we have it in front of us. So
you're welcome, Delegate Krebs.
It's not a question.
Excellent. Moving on to the last bill of the day, which is House Bill 1319. Delegate Howard, I hope is coming into the room as we speak. It's entitled Health Insurance, Lyme Disease, and Related Tick-Borne Illnesses, Long-Term Antibiotic Treatment. Do we have Delegate Howard here?
He hasn't joined us yet. I emailed him a few minutes ago.
Okay, we can wait for a minute. There's somebody named Tracy O'Riordan. Is that person here? Don't see Tracy. As excited as we are to be done, I think we should wait for a minute. Hopefully we can get Delegate Howard.
Madam Chair, if you'd like, I could probably present the bill for him.
Sure.
What's the bill number?
1319.
Is he still not in, Melissa?
No, and his phone goes to voicemail.
Okay. On behalf of Delegate Howard, House Bill 1319 requires insurers and Medicaid to provide coverage for long-term antibiotic treatment of Lyme disease and related tick-borne illnesses. A carrier may not deny coverage for treatment solely because the treatment may be categorized as unproven, experimental, or investigational in nature. The bill would take effect January 1st of next year and applies to all policies, contracts, and health benefit plans issued, delivered, or renewed in the state of Maryland on or after that date. That concludes my testimony.
All right, who's got the hardest question for Delegate Kipke on this bill? Nobody? I see no hands. You dodged something there, Delegate Kipke. I am just making
Wait, he's here now.
Oh, excellent. Okay, it looks like Delegate Howard is here.
Delegate Howard, I told everybody what your bill will do.
You did present it for me. Thanks, Nick.
Yeah, I don't know.
I really appreciate you guys waiting for me. I'm sorry I was in a discussion with Delegate Charkoudian in Public Utilities about RPS, and I really appreciate you taking the time to wait for me. So, Delegate Kipke, you did present the bill?
He presented the basics of the bill. He told us what it did, but if there's anything else you'd like to add, please feel free.
Well, thank you very much. Yeah, there's a couple things I'd like to add. I've been looking up some CDC data as far as Lyme's is concerned, and basically they base their data on 3-year averages. And as of 2018, Maryland had an 18.6% infection rate. In 2018, we had a confirmed 894 cases, a probable 488 cases. The CDC has classified Maryland as a high incidence state. And as of 2021, right now, based on the latest data, we're up to a 20.6% rate of infection as far as Lyme's is concerned. So we're seeing an increase in this. Also, too, very quickly, legislation throughout the United States to try to address this issue on various levels is not new. Maryland itself in 2007 had HB 836, which was required the Secretary of Health and Mental Hygiene in collaboration with other state agencies to establish and promote public awareness. That expired in 2009. Massachusetts in 2010 passed some doctor protections. Their bill HB 4683 amended existing law to permit licensed physicians to prescribe, administer, dispense long-term antibiotic therapy for a therapeutic purpose to eliminate infection or control a patient's symptoms from acute and late-stage persistent chronic infection. New Hampshire, 2011, more doctor protections. New York, 2002, doctor protections. Ohio and Pennsylvania, task force, 2002, doctor protections in Rhode Island. And in Vermont, 2014, doctor protections. So a lot of the states, and in 2013, Virginia, some education legislation. So a lot of states are starting to address this. As I said before, we are seeing an uptick, and this state is classified by the CDC as a high incidence state. I think it's time that we start to look at truly addressing this issue. I don't want to say that, well, only about 1,000 or 1,200 Marylanders have this. I mean, this is a very destructive disease, which you're getting ready to hear some personal stories about that. But I feel like we're sort of at that tipping point where if we don't really start to do something now, in the future, it could be a lot more costly and expensive. And I'm proposing the legislation so that we can start to take preventive measures so that right now we've got 1,000 people. In a couple of years, we could have several thousand people, and the cost is just going to grow. The wide path of destruction that this causes in people's lives is going to continue to grow. And that's why I brought the legislation forward. I'm looking forward to a favorable return on the legislation. I really appreciate you colleagues again waiting that minute or two for me. And I appreciate you hearing the legislation today. Thank you.
Thank you very much. And I see we do have Tracy O'Riordan here now. Tracy? Is Tracy?
Tracy, you need to unmute yourself.
Yeah.
Let's see here, see if I can give her a call.
Thanks.
Mm-hmm. Okay, it says she can't find the button on unmute. Tracy, I think it's the little red one there. It's got the down on the bottom left-hand side. I think it says mute or unmute.
Should be like a picture of a microphone.
She might be trying to sign back in too. So she got kicked out of the waiting room. Maybe she's back in the waiting room.
Melissa, do you see her in the waiting room?
Yeah.
I see her in the main meeting. We keep requesting her to start video.
Delegate Howard, do you, I see we have written testimony from Mary Jean Hughes, but we don't from Tracy O'Riordan. If we cannot get her hooked up, could you get us her statement written? Ah, perfect timing. Wonderful. Thank you.
I kept getting out, so it made it difficult to get back in. Sorry about that.
Well, that's okay. We're ready to hear your statement, and you're going to have a timer that shows 2 minutes.
Okay, thank you.
Sure, go ahead whenever you're ready.
Good afternoon, Chair and committee members and Delegate Howard for inviting me. Thank you very much for giving me your time. Lyme disease can be very devastating on the people who get it, the human body, the physical, the mental, friends and family. And to add injury to insult, we have insurance companies that refuse to pay for our treatments and even our testing. There's 2 main tests, the Alicia and then the Western blot. The Alicia, even John Hopkins came out and said that 5 years ago that it was 20% accurate at best. And most insurance companies refuse to do the Western blot if your Alicia comes back negative, even if it's a false negative. The Western blot shows more detail, but there's really better testing out there the insurance companies refuse to pay for, such as IGeneX. That can be, to $2,000 to $3,000 out of pocket that people have to pay for cash to find out exactly what part of this disease they have to be treated properly. I was on 3 different antibiotics at the same time, plus other medication, completely wiped out our bank account, our 401k. It made life very difficult for us. It destroyed my marriage. We had to sell our house, sell our boat. I now live with a friend that by the grace of God, for free, because I'm virtually homeless, because I even had to sell my truck to pay for my medical care because insurance just won't cover long-term treatment for patients with Lyme disease. It's great for if you're diagnosed early, but for someone with me who has chronic Lyme, I had it for 16 years before diagnosed. I will be 25 at the end of this month. I have had it half my lifetime and I am still struggling. In less than 6 years, I lost everything monetarily, because of having to pay out of pocket for doctors and medication because of the lack of insurance help. Thank you for your time.
Thank you so much for your testimony. Do we have any questions from members of the committee? Delegate Lewis Young.
Thank you, Madam Chair. I'd like to direct my question to the bill. Thank you, Madam Chair. I was muted. I'd like to direct my question to the bill sponsor. Adams, I'm sure you're aware that your bill is virtually identical to a bill that I brought in front of the committee about 2 years ago. And the oppositional testimony is identical as well. Given the fact that there is such controversy in the medical community between the Lyme literate doctors and the more traditional infectious disease specialists, the insurance companies are always going to have the out that there is no agreed upon cure or treatment. So what I'd like to know is what's different now than 2018, or what medical expertise is new to say that now's time?
Well, I just want to bring the legislation up and bring it forward. I mean, we legislators all the time set mean testing guidance and standards for industries throughout Maryland. I don't think that this is any different. I can't speak to any updated technologies or new technologies in testing and medicine distribution, but I know that that this disease is hurting thousands of people, and you know, the CDC itself has classified this state as a high incidence state. Their own numbers show a 10% increase in infections from this horrible disease. And I'm just not going to stand by and not do anything. I mean, that's the purpose of this body, is to set forth and regulate industries, as well as outline and guide industries in the future as far as legislation is concerned. So, I mean, I don't know if that answers your question. I'm sorry if it doesn't. I think you're more speaking to exact technologies. And I know you had the bill in 2018 and you did not bring it back last year. I think you were thinking about it. You and I were actually going to co-sponsor the legislation, and the legislation did not come back. But, you know, I feel strongly about it. I think it's time that we do something, and that's, you know, our job as legislators is to chart a path forward between the educated and non-educated doctors and the insurance companies on something that's a compromise.
Okay, but we also need to be able to respond to the opposition.
Delegate, you're muted.
I said, I'm sorry, I said, which is insurance companies. So I understand their opposition. I don't think it's wholly financial, but I'm sure that's going to be part of the conversation. But the fact of the matter is, and the fact still remains, is that the CDC has classified Maryland as a high incidence state. We can clearly show numbers from 2018 to 2021 that show a 10% increase in lives. So I would rather get ahead of this than sit on it, quite frankly.
Thank you very much. I'm looking for any further questions from committee members, and I don't see any. So that concludes the hearing on House Bill 1319 and the bill hearings before us today. So